Once again, welcome to all our dear viewers and members of the White Army for this special EPIGNOSIS national level surgery long clinical case presentation competition. This is more of a mock examination rather than a competition. We have continued version of yesterday's event. Yesterday, out of 22, 12 students have presented yesterday, and remaining 9 students will be presenting here. We have students all over the India, across the country, from all representing all the states, presenting variety of cases. So this is going to be a good preparation as well as a revision for all the final year students before the final exams. So once again, I would like to welcome our own mentor, patron of the White Army, Professor Srinivasan sir from Coimbatore Medical College for this session. Welcome to you, sir.
Welcome.
And today's special guest, I should say, is our own, but he's very special. This event is very special because it's a first event. It's again proved that how much he's passionate about teaching, how much he's dedicated to the teaching, and how much he loves his students. It's proved once again. Yes, our Professor Guru Shantappa sir, HOD of KIMS Hubli, he has won the ASI Association of Surgeons of India elections today, which was held for last month. Today results was announced in the noon. Still, immediately he messaged me, Kishan, today let's have class at 8 o'clock. That is the commitment, sir. Dedication. Hats off to you. Really, I feel like touching your feet from here.
No. Thank you.
No, sir.
Thank you.
No. We don't get people like you, sir.
Is my presentation visible, sir?
Yeah.
Okay, sir. Good evening, everybody. I'm Harris Richard, a final year MBBS student from Coimbatore Medical College, and I will now be proceeding with my case presentation. My patient, Mrs. XYZ, a 51-year-old female from Metupalayam, who is a domestic worker by occupation belonging to low socioeconomic status, came to the hospital with the chief complaints of an ulcer over the left side of the tongue for the past 3 months, associated with pain over the ulcer for the past 2 months. History of presenting illness: the patient was apparently normal 3 months back, after which he noticed an ulcer over the left lateral aspect of the tongue, which was insidious in onset. The ulcer was initially small in size and then gradually progressed to the current size, and it is not associated with any discharge. There is history of pain over the ulcer for the past 2 months, which is a pricking type of pain, which was gradual in onset and progressive in nature and aggravated on food intake, and there is no history of any ear pain. There is history of difficulty in speech present. There is history of difficulty in chewing present. There is history of swelling in the neck present. There is no history of difficulty in opening the mouth. No history of difficulty in protrusion of the tongue. There is no history of deviation of the tongue. There is no history of excessive salivation. No history of foul breath. No history of change in voice. No history of trauma from any sharp tooth or dentures, and no history of delayed healing of any tooth sockets. Past history: she has a history of tooth extraction done 2 months back for the removal of the right upper second molar tooth. There is no history of previous ulceration, whitish or reddish patch in the tongue. No history of previous surgeries in the oral cavity. No history of any venereal diseases. No other comorbidities present. Personal history: the patient has a history of betel nut chewing for the past 20 years. However, she stopped 1 month ago. There is no history of alcohol consumption. She is not a smoker, takes mixed diet, normal sleep pattern, normal bowel and bladder habits. Family history: there is no significant family history. Summary: a 51-year-old female who was a betel nut chewer with no known comorbidities presented with an ulcer over the left lateral aspect of the tongue for the past 3 months, associated with pain and with a swelling in the neck. General examination: after obtaining proper consent from the patient and with adequate lighting and privacy, the examination was carried out. The patient was COVID-19 negative at the time of examination. She was conscious, oriented, moderately built and nourished, with an ECOG score of 1. There was no pallor. She was not icteric. No clubbing, no cyanosis, no pedal edema, no generalized lymphadenopathy, no halitosis, and no drooling of saliva was present. Vital signs: pulse rate was 76 beats per minute in the right radial artery. Blood pressure was 110/70 millimeters of mercury, measured in the right arm in the sitting posture. Respiratory rate was 18 per minute, and she was afebrile. Examination of the oral cavity: on inspection, no obvious facial deformity was present. The lips were normal, no trismus present. Gums, alveolus, buccal mucosa were normal. Dental formula: right upper jaw 2121, right lower jaw 2122, left upper jaw 2122, left lower jaw 2122. Diffuse staining of teeth was present, and multiple dental caries were present. On the tongue, a single ulceroproliferative growth of size approximately 4x3 centimeters is present in the left lateral surface of the tongue, irregular in shape, extending anteriorly up to 1.5 centimeters proximal to the tip of the tongue, posteriorly up to the second molar tooth, laterally up to the lateral margin of the tongue, and medially it extends up to the midline. However, it does not cross the midline. The margins are ill-defined and the edges are reverted. The floor consists of white patches. There is no discharge from the ulcer and the surrounding area appears normal. No difficulty in protruding the tongue. There is no deviation of the tongue. The retromolar trigone is normal. Floor of the mouth appears normal. Anterior and posterior pillars appear normal. The uvula is in the midline. No tonsillar enlargement. Posterior pharyngeal wall appears normal. On palpation, tenderness is present over the ulcer proliferative growth. Inspectory findings of size, shape, and extent are confirmed. It is hard in consistency. Induration is present at the base of the growth, covering 0.5 centimeters around the growth. It does not bleed on touch. Floor of the mouth is not involved, and there is no mandibular thickening. Examination of neck nodes. 2 discrete nodes of size 2 cross 2 centimeters and 1 cross 1 centimeters are palpable in the left submandibular and submental levels, respectively. The lymph nodes are hard in consistency, mobile, non-tender, and skin oval swelling is normal. Other system examination, cardiovascular system, S1, S2 heard, no murmurs. Respiratory system, normal vesicular breath sounds heard, no added sounds. Abdomen is soft, there is no organomegaly, no free fluid, and no palpable mass. Central nervous system is clinically normal. Examination of cranial nerves 9, 10, and 12 were normal. Spine and cranium were normal. Summary, a 51-year-old lady who was a betel nut chewer with no known comorbidities presented with an ulcer over the left lateral aspect of the tongue for the past 3 months, associated with pain and with a swelling in the neck. On examination, an ulcer proliferative lesion on the left lateral aspect of the tongue with irregular margins, tender with surrounding induration, with 2 palpable lymph nodes in submandibular and submental levels were present. Provisional diagnosis. This is probably a case of carcinoma of the tongue involving the left lateral aspect of the anterior 2/3 of the tongue and involvement of level 1 lymph nodes in the neck with a TNM staging of T3, N2B, M0 belonging to stage 4A. Thank you. So you're not audible, sir?
Oh, sorry. Yeah.
Yes.
Harris, it was a very fluent presentation.
Thank you.
And very apt and compact, like in the sense you have given all the information in every slide. How this presentation was different from others which we saw in the previous presentations. You have given the information with every slide, not dragging the information because you have got a limited time. But there are few things which in the beginning. Yeah, can you put the history slide?
Yes, sir.
Do you want to present this case as an ulcer because you have presented in the history that she has presented with the history
Yes,
of ulcer?
sir.
So do you think this as an ulcer?
No, sir, I don't think this is an ulcer, but since the history has to be said in the patient's own words, I put it as an ulcer, sir. I confirm it. Yes, sir.
But your presentation will be after examining the patient. It is not that you take history and present the history to the listener. You examine the patient and then present the case.
Yes, sir.
Okay. So even if she says something wrong in the history, which we need to present as in patient's own words, you need to modify because you are a clinician.
Yes, sir.
So do you want to present this as a ulcer?
I would present this. I would present this as an ulcer proliferative case, which I've said on inspection. So on my inspection, I observed it as an ulcer.
No, that's different. That is different. I'm asking in the history. Even if she says ulcer, you would have presented as
ulcer proliferative growth.
Growth or some lesion, growth in the tongue.
Oh, growth.
She must have said growth in the tongue. Growth in the tongue. Okay, that is a point what I wanted to highlight. Next slide, please. You said patient has got a history of difficult. Next slide. Next slide. Yeah, what is this? History of difficulty in speech, chewing difficulty, and swelling in the neck. So she has that history, no? Difficulty in chewing and difficulty in speech.
Yes, sir.
What is that? Could it be because of what in this particular case?
So if the lesion has infiltrated the deep muscles of the tongue and the floor of the mouth, she will have difficulty in speech and chewing, sir.
This case, your case is different from other ulcerative lesions in the tongue.
Yes, sir. If the lesion has infiltrated the muscles of the tongue, sir, she will have difficulty in
this case. It is because of the mechanical factor. It is a proliferative lesion.
It is also very big. Yes, sir. Yes.
It is proliferative, occupying whole of the mouth inside. It is like keeping something inside the mouth and trying to speak out. Can you do that?
It's difficult, sir. Yes, sir. Because the size of the mouth is difficult.
Exactly. So you should have some lateral thinking when you have a case like this.
Yes.
What you are giving explanation, it holds good for all malignant lesions of the tongue. Okay, for this particular case, it is a mechanical factor which may be contributing for difficulty in chewing and difficulty in speech. Okay. What is that called? If there is a difficulty in speech secondary to infiltration into the floor mouth, what is that called?
It's called dysarthria, sir.
No. What is that process called? If the tongue is getting infiltrated into the floor mouth and causing difficulty in speech.
Tongue tie.
Tongue tie. No. This malignancy I'm talking about. It's called, if the tongue gets fixed to the floor mouth, what is it called?
Frozen tongue.
No.
I'm not sure, sir.
What is ankylosis?
Sir,
Ankylosis.
Ankylosing is.
Ankyloglassia. Tongue getting fixed to the floor mouth. Ankyloglassia.
Yes.
Okay. Is she able to protrude the tongue out?
Yes, sir. She's able to protrude.
Yeah, that itself rules out that she doesn't have like infiltration into the floor.
Yes.
That rules out straight away.
Yes.
So that may not be the cause for here difficulty in speech. So it is a mechanical factor, size of the lesion.
Yes.
You got the point. This is what
Yes.
I say for my student, lateral thinking.
Yes.
What you know is the theory. But for this particular case, that explanation may not hold good. So there has to be some other reason. And this is the reason for this particular case.
Okay, sir.
In the presentation, I heard she has undergone tooth extraction on the right upper molar, but the lesion is on the left side.
Yes, sir. Yes, sir.
So how can you correlate? Is it anything to do with the disease or you have mistakenly written?
I personally think there is no link between the tooth extraction and her current lesions, sir, because it's on the opposite side.
If this would have been on the left side,
it may have contributed to the lesions, sir.
how?
So there may be delayed healing of tooth sockets, which may be prone to infection or even bone erosion.
Not tooth sockets. It is a sharp tooth. Probably the dental surgeon must have been extracted.
Yes, sir. Yes, sir.
Okay. You said there is no protrusion. Any other way you can explain the protrusion other than infiltration into the floor mouth? Protrusion and deviation of the tongue? Some other ways you can explain?
Maybe nerve involvement of the lesion, sir.
Which nerve?
Hypoglossal nerves.
Okay. How hypoglossal nerve can be involved? Is it by the primary or by the secondary deposits? Both can happen, but which is more likely in tongue lesions?
Primary, sir.
Primary, it's a muscle infiltration. The nerve comes from the submental foramina, submandibular foramina. Nodes can infiltrate there.
Sorry.
Okay, next slide. Okay, next slide. Why did you ask for excessive salivation?
So it is since the lesion is on the tongue, it is primarily an irritated lesion, and also there is decreased. She already has difficulty in chewing, so there's going to be difficulty in swallowing as well. So there may be excessive salivation present, sir, in this case.
What does it irritate to cause excessive salivation?
The tongue, it's an irritative lesion present on the tongue, sir, and also there's restricted
irritating tongue. Irritating what? So that there will be increased secretion. It's an exposed free nerve endings. Exposed free nerve. Once there is ulceration, and second is whenever things are asked about a gland where there is an excessive collection, whether it is a hydrocele, submandibular gland, parotid gland, or in the mouth, whenever things are asked like this, it could be because of increased secretion, defective absorption, or defective transport.
Okay.
It holds good for any secretions anywhere in the body, even including the CSF, if it's a hydrocephalus. So here either excessive secretion or defective swallowing, because we swallow saliva.
Yes.
So either of the two increases it feels that excessive secretion. You got the point. Both contribute in tongue lesions. Okay, next line. So at history level, probably what do you think for this lady?
It is probably a malignant lesion of the tongue.
Malignant lesion. Okay, fine. If you feel that it is because of the mechanical big lesion in the tongue and then causing all this problem, does it go in favor of a malignancy or a benign disease? Because of the mechanical factor.
So the growth has progressed to such a size in about 3 months, sir. So I would probably suggest think of malignancy in this case.
Okay, fine. I don't want to confuse you people for undergraduates. It's all right. Okay, fine. Because there are few specific diseases where tongue will become big and they will have a surgical illness. What is a big tongue called otherwise?
Macroglossia.
Macroglossia. Is it seen in surgical diseases or medical diseases commonly?
It's in hypothyroidism, we get macroglossia.
Yeah, medical illnesses more often, but you have particular surgical diseases where you can expect this. Like one of them is lymphoma. Just it is for information, not to mention in the examination.
Okay.
Next slide. Okay, next slide. Okay, so in the examination now, come back to the inspection, which you have described nicely, and you have accepted that yes, you have put it as a proliferative lesion rather than an ulcerative lesion.
Yes.
Okay, you should be very, because you have put a nice photographs and it is coming out of the surface and it is a proliferative lesion. Nicely you have described. And I am not happy with your palpatory findings. In the sense, I expected, because it looks like a cauliflower growth, wherein the flower has come out and probably it has got a stem down. So you should have highlighted in palpation, are you able to pass your fingers underneath the margin of the growth?
Okay, sir.
Are you able to understand this?
Yes, sir. Yeah. Yes.
So whenever you have a case like this, which is different from the routine cases, you need to use your lateral thinking and do your own way of doing the examination, which may not be mentioned in the classical clinical method books.
Okay. Sir.
Okay, because it looks like a cauliflower growth, so it will have underneath. So did you mention that? Or I want to know, did you do that? Are you able to pass a finger underneath that margin of this growth?
Sir, when I tried to palpate the posterior margin, I did palpate the underneath the growth behind posterior margin. I didn't palpate around the ulcer. So
anteriorly, are you able to put the finger between the growth and the tongue? Are you able to?
Sir, when I did it posteriorly, my finger automatically went under the growth, but it didn't go anteriorly. But I didn't specifically check in the anterior.
It looks like anteriorly. It looks like it is on the surface of the tongue, sitting like this.
Yes.
Why it is important? You are able to understand my description. It is like a tree, stem of the tree and then tip of the tree.
Yes.
So what is the importance of that in this case?
So it may be important in the surgical management where we may need to excise a smaller area of the tongue rather than such.
Exactly, depending on the induration.
Yes, sir.
Depending on the induration. Okay, that's important. And the extent of induration, I think you did not highlight. What is the extent of induration here?
0.5 centimeters around the growth, sir.
Okay, over the tongue.
Yes, sir.
And it is not crossing the midline.
It is not. It extends up to the midline, but does not cross the midline, sir.
What about the posterior 1/3 of the tongue in this case?
It is not involved, so there is no extension to the posterior 1/3 of the tongue.
Okay, fine. Examination in the photograph, it looks like level 2 notes, but you have mentioned in the final diagnosis level 1 notes.
So there were submandibular notes involved.
So it is a submandibular? Okay.
Yes. Yes.
Okay. Where is the level 2 notes?
Level 2 nodes are upper jugular.
Okay. So in the photograph, what you have shown is a submandibular.
Submandibular.
Okay.
The submental was not visible, but it was palpable under the chin. So.
Fine. For the time constraint, probably, sir, I think we should go for the how to evaluate.
Yes, sir. Please, sir.
Yeah. Okay. What do you want to do now?
So I would start with the investigations, routine investigations, such as I would want to investigate to confirm my diagnosis, to know the extent of the tumor, and also for anesthetic purposes, and also to rule out metastasis. So in this case, I would start with routine investigations such as complete blood count, blood urea, blood sugar, serum creatinine, liver function tests, X-rays, and ECG for anesthetic purposes. After which I would move on to specific investigations, which in this case would be an edge-wedge biopsy, sir. I would also like to do an ultrasound of the neck to look for any clinically non-palpable lymph nodes. And after that, I would like to do an ultrasound guided FNAC of the lymph nodes. And to properly examine the posterior 1/3, I would like to do an indirect or direct laryngoscope as well, because the posterior 1/3 is a part of the oropharynx. It's not properly examined. And I would also look for mandibular extension. I would like to do an X-ray of the mandible or CT. And though unlikely, if there were any posterior extensions, I would like to also rule out distant metastasis to the lung, liver, or bone with appropriate investigations. And after that, the treatment part, I would like to perform hemiglossectomy in this case with a modified radical neck dissection on the ipsilateral side. And if clinically non-palpable, if the other side is N0, I would like to do a supraomohyoid type of neck, selective neck dissection on the contralateral side. So.
Oh, everything you have finished without our questions of treatment. Okay, you have come like, okay, fine. You will do edge-wedge biopsy. What is the histology you expect in this case?
I would probably suspect squamous cell carcinoma in this case.
Squamous cell carcinoma, and FNAC of the nodes you mentioned. Okay.
Yes.
And now,
yes.
we may not accept, even Srinivasan sir may not accept as an investigation modality to evaluate distant or a systemic spread into the lungs, brain, and bone, which you mentioned. We don't expect that in tongue lesions because they are squamous cell carcinoma deposits. So I think you should not be mentioning that extensive metastatic workup for tongue cancers.
Okay.
Loco-regional disease, yes, loco-regional. If patient has got obvious symptoms, then you need to evaluate for a systemic disease. Okay.
Yes.
Otherwise, unnecessarily you'll be inviting many questions or what malignancies will have lung deposits, what malignancies of the tongue will have brain deposits.
Okay. Okay.
Like that discussion will go off. Okay.
Okay.
We'll stick to the tongue and the neck.
Okay.
Yeah, if it is what all things you want from the biopsy? Is it just a squamous cell carcinoma, or you want to have the details?
Sir, I would the biopsy of the lesion, sir.
Yeah.
So I would like to know.
Fine. It's all right. For UGs, if you mentioned that, what I wanted was you need to know what is it well differentiated or poorly differentiated. By what means? There are many things. Okay, now it is a squamous cell carcinoma of well differentiated cancer in the tongue with such an extension and posterior 1/3 tongue free with the neck nodes which are deposits in the submandibular gland. So what will be your treatment?
Yes, sir. For the neck nodes, I would like to do a modified radical neck dissection.
No, mention for the primary first. I have given a scenario.
I would like to do a hemiglossectomy with. In this case, I would not want to reconstruct the tongue because I will allow it to granulate and re-epithelialize. If we have to do a wider excision, in that case, I would like to reconstruct the tongue, sir. And I would like to do a modified radical neck dissection on the left side. And on the N0 side, I would like to do a supraomohyoid type of neck dissection.
So you want to address the opposite neck also?
Yes, sir. Because tongue, it is capable of producing bilateral lymph nodes or contralateral lymph nodes. So I would like to do a supraomohyoid type of neck.
This lesion, can it have contralateral neck nodes? This lesion?
It could, sir. Yes, sir. It could.
Why? What is the reason?
So the tongue has decussation of lymphatics, so there could be contralateral side lymph nodes involved. Okay,
fine. I will accept this, but it depends on the examiner. If neck nodes are on the affected side, definitely you need to have like what you have mentioned, MND. And if the tip is involved and crossing the midline, then likely that the opposite side nodes may be involved. So if it is clinically N0, what you have mentioned, SOND, and then decide further treatment is accepted.
Yes.
Why MND on what is MND?
Modified radical neck dissection, sir.
What is it?
So it involves the removal of the it involves the preservation of the spinal accessory nerve, the sternocleidomastoid, and the intrajugular vein. And this is how it is different from radical neck dissection, where these structures are not preserved. So.
Okay. Do you have any adjuvant treatment modality for tongue lesions?
We can also advise radiotherapy, preoperatively debulk the tumor, or even postoperatively as a palliative therapy. Chemotherapy, it can be given as post-op as a palliative therapy or as a palliative therapy. We use the Price Hill regimen with the drugs like methotrexate, vincristine, bleomycin, adriamycin, etc.
Okay. Just for information at UG level, remember if it is asked like this, adjuvant treatment, invariably radiotherapy will be an adjuvant treatment after surgical treatment. If you are choosing chemotherapy, invariably chemotherapy will be as a neoadjuvant treatment for unoperable cancers of the tongue. Okay, chemo will be before, invariably for advanced. Radiotherapy, definitely it is adjuvant treatment for all. It has got its own indications, which probably, if you know, it is better. So you just remember, neoadjuvant, chemo first. Adjuvant, if it is asked, invariably it is a radiotherapy which is chosen first after surgery. Okay. Yes, thank you. Well done. Sir, yeah.
You're good to go.
Thank you. So good evening to all the respected teachers present here. I am V. Kirtika, a final year student from Coimbatore Medical College, and I will be presenting a long case today under the guidance of Dr. Srinivasan sir. My patient, a 42-year-old male, an auto driver from Coimbatore, presented with the chief complaints of pain in the right foot since 3 months. History of presenting illness. My patient was apparently normal 3 months back, after which he developed pain in the right foot which was insidious in onset, gradually progressive in nature. It was continuous, severe pain, which was cramping type. It was aggravated on lying down during sleep, and it was relieved by hanging leg down by the sides of the bed. There is no history of pain in the calf, thigh, and gluteal region. There is a history of blackish discoloration of right fourth toe 2 months back, for which he underwent disarticulation of the right fourth toe at a local hospital. There is a history of ulcer following disarticulation of toe 1 month back. There is history of loss of sensation in the right foot. No history of fainting, transient blackouts. No history of chest pain. No history of abdominal pain. No history of reduced urine output. No history of fever and trauma. No history of swelling and redness over the affected part. No history of impotence. Past history, there is a history of disarticulation of right fourth toe done 1 month back. The patient is not a known case of diabetes mellitus, hypertension, coronary artery disease, and cerebrovascular accident. There is no history of other past surgeries. Personal history, the patient is a smoker for the last 20 years. He smokes 1 pack of cigarettes per day. He's not an alcoholic. There is no history of tobacco nut chewing, betel nut chewing. The patient takes a mixed diet and has normal bowel and bladder habits. There is no relevant family history. Summary, a 42-year-old man, a known smoker, presented with rest pain in the right foot for the last 3 months, probably a case of peripheral vascular disease of the right foot with absence of the fourth toe. General examination, the patient is conscious and oriented, moderately built and nourished, afebrile, no pallor, not icteric, no clubbing, no cyanosis, no generalized lymphadenopathy, no pedal edema. Vitals, the temperature is 98.5 degrees Fahrenheit. The blood pressure is 120 by 80 in both arms, measured in supine position. Pulse is 79 beats per minute, measured in the right radial artery in sitting posture. Respiratory rate is 14 per minute. Other systems examination, CDS, S1, S2 heard, no additional murmurs. RS, bilateral normal breath sounds heard, no added sounds. Abdomen is soft and non-tender, normal bowel sounds are heard. Inspection of the right foot. After obtaining proper consent from the patient, the lower limbs are exposed completely from the anterior superior iliac spine to the toes and are examined under adequate privacy and adequate light. The attitude of the limb, the hips and knees are extended, ankles are dorsiflexed. Right fourth toe is absent. An ulcer of 3 × 1 centimeters is seen over the right fourth digital space. Floor is covered with slough, edges are overhanging, margins are irregular, there's no discharge from the ulcer. Surrounding skin is hyperpigmented. The surrounding skin shows ischemic changes like thinning, loss of hair, and subcutaneous fat. Nails show transverse ridges and are brittle. Toe and ankle movements are normal. Another 2 × 2 centimeter healed ulcer seen over the dorsum of foot. Berger's postural test. A gangrenous toe has already been disarticulated, indicating severe ischemia. Left lower limb appears normal and there are no engorged veins present. Palpation of the lower limb. The right foot is cold when compared to the left foot. The skin temperature feels normal till the level of the right ankle. Right fourth toe is absent. And an ulcer, 3 × 1 centimeter size, is seen over the right fourth digital space. Floor is covered with slough, edges are overhanging, margins are irregular, no discharge from the ulcer. Surrounding skin is hyperpigmented. The base of the ulcer over the fourth digital space is formed by muscles and the head of metatarsals. Examination of the peripheral pulses. In the right limb, the dorsalis pedis artery pulse and anterior tibial artery pulse is absent. The posterior tibial artery pulse is feeble, whereas all the other pulses are felt normally. In the left limb, all the pulses are felt normally. Sensory examination. Crude touch and fine touch, pain and temperature sensation is lost over the right foot. Plantar reflex is absent on the right side. Motor examination. Movement of the ankles and toes are normal. The tone of the muscles is normal. Power is normal. Bulk is normal. And both the lower limbs measure equally in circumference, which is right and left lower limb. The calf measurement is 35 centimeters and thigh measures 50 centimeters. Examination of the left lower limb is normal. Examination of both upper limbs are normal. Regional lymph node examination is normal. Summary. A 42-year-old man, an auto driver, a known smoker for the last 20 years, presented with rest pain in the right foot for 3 months. On examination, there is absence of right fourth toe with absent dorsalis pedis pulse and anterior tibial artery pulse and feeble posterior tibial artery pulse. Right foot skin shows ischemic changes. Probably a case of peripheral vascular disease of the right foot due to Berger's disease with disarticulation of the right fourth toe due to gangrene. Thank you.
Yeah, Kirtika, it was like a very clear presentation.
Thank you, sir.
Only here and there, you should have avoided 2-3 slides, just mentioning everything is fine, so that you would have got
Okay.
more time.
Okay, sir.
And with good clinical photographs. Just for clarification,
Yes, sir.
is that it is the area where he underwent amputation? That is the area where he has ulcer now. Am I right?
Yes, sir. Yes, sir.
Okay. He means in the sense after surgery, was the wound closed or wound kept open and that has resulted in an ulcer? What is the story?
Wound was kept open, sir.
Okay. So it is after surgery, wound has, like, it was not closed and it has resulted in wound. It has not healed.
Yes, sir.
Okay. Okay. So it is a surgical wound which has not healed.
Yes, sir.
Okay. What is the inference of this?
There is no proper blood supply, so no proper nutrients required for healing.
Why do you think the wound was kept open? Because we surgeons are fond of closing all the raw areas. So why
Yes,
did
sir.
that surgeon kept the wound open?
For better healing, sir.
Better, it has not healed. No, if that is the intention, it should have healed by this time. If a surgeon keeps the wound open, means what? Surgical wound, which has been done in operation theater.
Not to injure any surrounding vessels or nerves.
No, no. What is the idea? Why we keep wound open?
I'm not sure.
Probably there was an infection. You said gangrene, no? Blackish discoloration
Yes,
of the toe for
Yes,
which
sir.
he underwent. So
Okay.
probably there was an infection at the site where
Okay.
it has disarticulation was done. If it is
Okay.
an infected area, we never close the wound.
Okay.
In the sense, what was that gangrene that time when he underwent the amputation or the disarticulation? Probably it was
Infected gangrene, wet gangrene.
otherwise wet gangrene.
gangrene.
Wet gangrene. That is why it has not been closed.
Okay, sir.
Okay.
Yes.
Okay. Fine. How did you palpate for anterior tibial artery here?
The anterior tibial artery can be palpated midway between the two malleoli in the anterior aspect, sir.
Okay. How do you palpate for the posterior tibial?
Posterior tibial artery pulse can be just felt behind the medial malleolus, midway between the medial malleolus and the Achilles tendon.
Achilles tendon. Okay. Which is out of these three, dorsalis also you said, which is the most important artery where if it is not felt, it has got a significance out of three? Which artery?
Dorsalis pedis artery, sir.
See, whenever such questions are asked, no,
Yeah.
is a dorsalis pedis artery normally it can be absent in some people?
Yes, sir. It can normally be absent in
So
some people.
can it become an important artery
No,
if
sir.
it is normally also if it is absent?
No, sir, no.
So it is not important.
Okay.
Absence of dorsalis doesn't mean anything. Limb
Okay.
can be normal, even dorsalis pedis being absent. So which
Okay.
is that important artery of blood supply to the foot?
Anterior
Posterior
tibial.
tibial.
Posterior tibial
tibial artery.
Okay, sir.
Posterior. That is the biggest among three.
Okay, sir.
Posterior tibial artery, which has
Okay.
got many branches. Once it crosses that area, it
Okay.
goes to the sole, and then it takes
Okay.
another part in the anastomosis between plantar,
Okay.
dorsal and plantar, the blood vessels.
Okay.
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 Okay. Fine. So you think it is a peripheral vascular disease,
Yes, sir.
secondary to?
Thromboangiitis obliterans, Berger's disease.
Okay, fine. Why do you think I say it is atherosclerosis?
So the patient is a smoker and his age is 42 years old, and he doesn't have any other risk factors like diabetes and coronary artery disease, hypertension. So probably it can be because of atherosclerosis, because he could have undiagnosed diabetes mellitus conditions, but this case is probably due to Berger's because he's a smoker and the age, sir.
Fine. How do you proceed now? One
Investigation.
more thing, just for information for the undergraduates, there are some examiners, many clinical examination findings which are not mentioned in this particular case, that ankle brachial index.
Yes, sir.
Okay, the other
Yes.
examination of pulses, like many things which I think you should be knowing, because some examiners are very fond of that.
Okay.
You should know how it is being, and capillary refilling,
Yes, sir.
venous engorgement. There are so many things
Yes, sir.
which
Yes,
probably as myself I may not appreciate doing all that, but people
Okay.
may ask. You should be knowing if they are
Okay, sir.
asking.
Okay, sir. Okay, sir.
Okay, how do you proceed now?
Here, in this case, I will do basic investigations to rule out diabetes mellitus dyslipidemia, like lipid profile, blood sugar, and all that, sir. And to localize the pathology, I would do an arterial Doppler and an angiography and proceed based on the results, sir.
What angiography you asked for?
CT angiography.
CT angiography. If you mention just angiography, it is understood that you are asking for invasive angiography, that is classical angiography.
Okay, sir.
So
Okay,
if you
sir.
really want, you should mention CT angiography.
Okay,
CT
sir.
angiography. That's
Okay,
what is
sir.
nowadays being done. Okay.
Okay, sir.
It has got
Okay.
its own indications. So doing a
Okay.
classical angiography has got indications, which I
Okay.
don't want to discuss. Okay.
Okay, sir.
What all things you would like to know from doing Doppler and CT angio?
So, if there are blocks and where the localization of the blocks, and if there is any if there are collaterals to the distal parts, and if there is any associated vein involvement, other vessels are involved.
Okay, if you have attended yesterday's class, I had mentioned, no, one is site,
Okay,
where
sir.
exactly is the block. Second
Okay,
is
sir.
extent, how far?
Okay, sir. Okay.
Extent.
Okay, sir.
Then what has happened to the collaterals?
Okay, sir.
Then are there any multiple blocks?
Okay, sir.
Okay.
Okay, sir.
Then you need to classify, is it a proximal vessel disease or a distal,
Or a distal
vessel
vessel
disease?
disease. Yes,
Okay,
sir.
depending on
Okay.
the findings. So here you feel it's a distal vessel or a proximal vessel disease?
This is probably a distal vessel disease, sir.
Distal vessel disease. Okay, what do you want to do? Okay, you have done a CT angio and a Doppler mentions
Yes,
that yes, there is a block at the anterior tibial artery just above the ankle,
Okay.
and remaining proximal vessels are patent
Okay, sir.
with minimal collaterals. You
Okay,
expect
sir.
more collaterals or minimal collaterals in such a scenario?
Minimal.
You expect, why
Yes, sir.
minimal? Why?
Because the foot shows ischemic changes, sir.
No. I have mentioned the site of block. So we expect minimal collaterals or a maximum collaterals. More proximal is the block,
Yes, sir.
more collateral development is a possibility.
Okay,
More
sir.
distal the block,
Lesser
chances of collaterals are very less.
Okay,
very
sir.
less. Okay. So what do you want to do for this man?
So initially smoking cessation, sir.
Very good.
And then lifestyle changes like and probably graded exercises to improve collateral circulation, like Burger's exercise. And
so you ultimately want to do surgical or medical management for this man?
so if there is gangrene, then surgical management.
No,
sir.
not if. You have a photograph here and you have a patient. So what,
Medical.
already they have done what is to be done, they have done already.
Yes, sir. Yes, sir. Medical management, sir.
Medical. Any drugs you want to use?
So yes, sir.
It's
Antiplatelet.
not a diabetic you want?
Yes, sir. Antiplatelet drugs, aspirin, clopidogrel, silestazole.
Definitely. They have got a role in
A
this
lot of
particular.
it.
Okay. Okay. Thank you. Sir, anything, sir? Srinivasan, sir?
Well done, God.
Thank you.
Yeah.
Thank you, Kirtika.
Thank you, sir.
Next, we have Mr. O'Neill. O'Neill. Yes, sir. Yeah. Start. Next, Miss Riddhi Soni, be ready. Okay.
Yes, sir.
Riddhi Soni.
So is my screen visible?
Yeah, you can start.
Okay, sir. Good evening to everybody present here. I am Onil Akash Biswas, fourth year MBBS student from St. John's Medical College, Bangalore. So presenting to you a case of Mr. XYZ, who is a 63-year-old man, tea plantation worker by occupation, resides in Bepanhalli, belongs to lower middle class as per modified Kutuswami scale, admitted on 24th October and examined the next day on 25th October. He came with chief complaints of swelling in the right groin since past 2 years and pain in the right groin since past 4 months. Patient was apparently well 2 years back when he noticed the swelling in the right groin while coughing, which was initially small in size, approximately 2 inches, gradually increased to the present
Only
size.
can you enlarge the slides? Can you make it full screen?
Sir, actually, when I'm trying to make it full screen, it's crashing, sir. That's why.
Oh,
sir.
fine. Don't do anything. Then present. Finish it off.
I'm sorry
Do
for the
it
inconvenience.
fast. Yeah, do it fast. No problem. Do it fast. Before it crashes, you can finish.
Yes, sir. The swelling increases in size when standing, coughing, and lifting heavy weights. It decreases on lying down and disappears on manipulation, where he uses his own fingers. There's no history of swelling in the left groin or elsewhere on the body. He complains of mild, dull aching pain in the right groin since past 4 months, which increases while straining and relieves on lying down. There's no history of abdominal pain, distension, vomiting, acute onset of any severe pain, or any rapid increase in the size of the swelling. There's history of chronic cough with sputum since past 10 years, no history of any chronic constipation, nor of any other lower urinary tract symptoms like frequency or urgency. Past history, the patient is a known case of COPD and is on bronchodilator since past 10 years. He is not a known case of hypertension, diabetes mellitus, or tuberculosis. There is no history of any swelling in groin or any other parts of the body before the present one. No history of any other prior lower abdominal surgeries. Personal history, the patient has been smoking regularly since past 43 years, consuming 2 cigarettes per day. He does not consume alcohol, sleep and appetite are normal, non-vegetarian diet, and bowel and bladder habits are regular. There is no significant family history over here. The patient regularly takes salbutamol inhaler since past 10 years. He does not have any history of any drug allergies. Summary, 63-year-old man, tea plantation worker by occupation, with smoking history for 43 years and a known case of COPD under medication. History of swelling in the groin since 2 years, which increases on coughing, straining, decreases on lying down, disappears on manipulation, gradually increasing in size and now extending into the scrotum. History of mild dull aching pain in the groin since past 4 months, which aggravates on coughing and straining, but relieves on lying down. Physical examination, after taking consent, patient was adequately examined in a well-lit room. General survey, the patient is conscious, well-oriented to time, place, and person, moderately built and well-nourished. Has a body mass index of 24.1 kg per meter square. His pulse is 86 beats per minute, normal in volume and rhythm. Blood pressure is 136 by 86 millimeters of mercury. Respiratory rate is 18 cycles per minute, abdominal thoracic. Temperature, he is afebrile. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema, skeletal deformity, or any dehydration. Coming to local examination, he was examined in the standing position and in supine position, and he was adequately exposed from the umbilicus till the mid-thigh. On inspection of pyriform shaped swelling present over the right inguinal region, which extends from above the medial half of inguinal ligament till the scrotum, approximately 6 cm into 3 cm in size. The skin over the swelling is normal. The swelling expands on coughing. No visible peristalsis seen. Left inguinal region is normal, and the penis is slightly pushed to the opposite side. On palpation, a swelling of size 3 into 6 cm is seen, medial and above to the pubic tubercle. There is no tenderness, no local rise of temperature. The swelling is soft and elastic. It is not possible to get above the swelling. Testis is felt separately from the swelling. Expansile cough impulse is present. Swelling is reduced manually with a gurgling sound. Deep ring occlusion test is positive for indirect inguinal hernia. There is no inguinal or scrotal swelling on the opposite side. Examination of the tone of the abdominal muscles. There is no undue protrusion of the lower abdomen on standing position. Malgagneous bulgings are not seen. Tone of the abdominal muscles is normal. Examination of the external genitalia. Scrotum skin is normal. Both the testes are normal. Spermatic cord is normal. The penis is normal. There is no phimosis. Meatus is normal. No discharge seen. Urethra is normal and there are no strictures present. Inguinal lymph nodes are not enlarged on both sides. On doing digital rectal examination, the prostate is normal. Systemic examination, respiratory system, respiratory movements are equal on both sides. Bilateral air entry, bilateral decreased breath sounds with prolonged expiration, bilateral rhonchi are heard, no precipitations heard. Abdominal examination, no scar marks, organomegaly or palpable mass. Respiratory movements are normal and equal in all corresponding quadrants. No abdominal tenderness, ascites heard. Bowel sounds are present and are normal. CVS S1 and S2 are heard, no murmurs are heard. CNS, there is no focal neurological deficit. Summary, a 63-year-old man who is a tea plantation worker by occupation with history of smoking since 43 years, a 10-year-old known case of COPD with history of chronic cough, presented with reducible right groin swelling since 2 years and dull aching in the right groin since 4 months, with no history of constipation, abdominal distension, vomiting, or rapid increase in size. On examination, piediform shaped, non-tender, reducible right-sided inguinal scrotal swelling, which lies above and medial to the pubic tubercle, with expansile cough impulse and deep ring test positive for indirect inguinal hernia. So my provisional diagnosis is right-sided, indirect, incomplete, uncomplicated, intrusive. Thank you.
Yeah, it was a fluent presentation, Neil.
Thank you, sir.
In the diagnosis, you would like to put something for this particular patient other than what you mentioned?
So like we know he's already a past, he's a known case of COPD, sir. So it's secondary.
Yeah, I think in this case, you need to highlight that because he is on medication, he is a smoker and last 20 years he has got that problem.
Yes, sir.
So right-sided, indirect, incomplete, uncompletely intrusive with COPD.
Okay.
Because still he is on medications.
Yes, sir. Yes, sir.
Okay, it was
Yes,
not
past
treated
10 years.
and he became all right. He has the disease now,
Yes, sir.
which you have detected in your clinical examination also. And the history is there. So better you should include with COPD.
Okay, sir. Sure.
With COPD. That completes your diagnosis. I say it is a hydrocele. How do you disprove?
So hydrocele, first of all, in hydrocele, it will be like, if we see, we will be able to get above the swelling since it's a scrotal swelling, whereas this is an inguinal.
Yeah, this is the mistake all of you do as an undergraduate. My question was, how do you disprove? Means you have a case, you have elicited some findings, you should stick to your case and your findings, and you should disprove me. Don't try to substantiate that it is not hydrocele. You try to substantiate that it is hernia.
Okay.
You got the point?
Yes, sir. Yes, sir.
You have elicited your findings now. So how do you now put that now?
So I was unable to get above the swelling.
One.
So there is an expansile cough impulse present.
Second.
It is reducible, sir.
Exactly. Very good. Okay. So these are the 3 points which will strongly in favor of hernia, not the hydrocele. You got the point?
Yes, sir.
You have elicited these points. Okay. So stick to your point. If I say some XYZ looks beautiful, you should find out, yeah, because of these points, she is beautiful. Don't take the not beautiful points and then try to substantiate.
Okay, sir.
You got the point?
Yes, only the positive findings, sir.
Exactly. What you have elicited in your case.
Sure, sir.
Take those points to substantiate your diagnosis. Okay. What is that you would like to do?
So since this is a case of hernia, so we have to go for surgical management. So I will take him up for surgery. So I would like to take him up for hernioplasty, sir.
Why do you want to operate on this patient?
So because I want to avoid him going into any complications, sir.
Very good. What are those complications you expect?
So like, for example, first of all, it can become irreducible, sir.
Okay.
Then it might get obstructed or it might get strangulated also.
Okay. What is the difference between irreducible hernia and obstructed hernia?
So irreducible hernia means we'll be unable to reduce the hernia. Whereas obstructed hernia, the cough impulse also will be absent and there is it's causing an obstruction, sir.
What obstruction? What is the difference? Both are not reducible.
Yes, sir. Like cough impulse will be present, sir, in case of obstructed hernia.
No, not
necessarily. It will be absent in case of obstructed hernia, whereas it will be present, sir, in case of irreducible hernia.
No, in both it is absent. Because you are not able to empty, no. If you cannot empty, you cannot appreciate the cough impulse. What is the difference? If you say obstructed hernia, what is that means? Obstruction of what?
So obstruction of the contents of the sac, sir.
No, it is a luminal obstruction. If you say obstructed, invariably the contents are intestine and that is getting obstructed. If you say irreducible, possibility of momentum being there.
Okay.
Okay.
Yes, sir.
What is the difference between strangulated and obstructed hernia?
So in strangulated hernia, the blood supply is also compromised, sir.
Okay, fine. So to prevent complications, you need to operate on this man.
Yes, sir.
Okay, what is the precaution you will take while operating this gentleman because he has got other medical illness?
So first of all, for that, I need to do the preoperative investigations.
Okay.
So I'll do the routine investigations, blood investigations, serum urea, serum creatinine, especially ECG needs to be done. And then I need to further, though it does not suggest of any BPH, because at this age, it might be common. But then, so to confirm that, I can get an ultrasonography done to look for the post-vital residual urine.
Okay. So what is the surgical procedure you would like to do?
So I would like to go for a lichen stents tension-free mesh annuloplasty over here.
Okay, fine. Any particular anesthesia in this particular patient?
So I could go for spinal anesthesia, sir.
Okay, spinal or regional or
Yes, sir.
local anesthesia?
Yes, sir.
Because he has got a COPD. Okay, fine. Next.
Good evening, everyone. My name is Riddhi Soni. I'm a final year MBBS student. My patient, Miss XYZ, a 35-year-old housewife, a resident of Alibag, was admitted on the date of 10th of October 2021. She presented with a chief complaint of a swelling in the front of the neck since 2 years. The patient was apparently all right 2 years back when she noticed a swelling in the front of the neck. The swelling was small to start with and gradually increasing in size from 2 into 2 centimeter, which then progressed to a size of 6 into 5 centimeter. She had no history of rapid increase in the size of swelling, pain, fever, or dyspnea, dysphagia, hoarseness of voice, or weakness, lethargy, puffiness of face, intolerance to cold, dry skin, menorrhagia, or constipation. Nor did she have any complaints of intolerance to heat, sweating, oligomenorrhea, diarrhea, irritability on slight provocation, insomnia, tremors of hands, or proximal muscle weakness, similar swellings on the lateral side of the neck, any bony pain or swelling in the vertebrae, pelvis, or skull, or any history of cough. Personal history. Her appetite was normal. Her diet is usually mixed. Bowel and bladder regular. Sleep is normal, and no intake of any drug in the recent past. Her menstrual history. Her menarche started at the age of 14 years of age. She has regular cycles of 29 days, which last for 5 days, and 2 pads. She uses 2 pads per day. Family history. No history in the family before, and no similar history in the neighborhood as well. She has no history of asthma, tuberculosis, hypertension, or diabetes mellitus, or any radiation exposure in the neck, head, and chest region in the past, or any treatment of other thyroid disorders. Summary. A 35-year-old female comes with a complaint of swelling over the front of neck since 2 years with gradual increase in size, which is not associated with pain, hypothyroidism features, any pressure symptoms, or metastatic symptoms. General examination. Consent under adequate illumination. Consent was taken and she was examined under adequate illumination in the presence of a female attendant, and she was exposed till the sternum. The patient was conscious, cooperative, and well oriented to time, place, and person. Pulse 93 beats per minute, regular rhythm, normal volume, force, and tension. No radioradial delay or radiofemoral delay. All peripheral pulses felt bilaterally. Pressure 110 to 70 mm of mercury in right arm in supine position. Respiratory rate 18 cycles per minute. Temperature 96.6 Fahrenheit measured in the axilla. Her BMI was 22, moderately built, skin not moist or dry, no signs of Graves' ophthalmopathy, pallor absent, icterus, clubbing, cyanosis, lymphadenopathy, and edema absent. The patient was examined with due consent under adequate illumination with a female attendant, and she was exposed till the sternum. On inspection, a single swelling which is 6 to 5 centimeter and globular in shape, which is present in the front and extending superiorly up to the thyroid cartilage, inferiorly 1 centimeter above the sternal notch, and laterally up to the anterior border of the sternocleidomastoid. The surface seemed smooth, margins well defined, lower border of the swelling is well defined and visible. Skin over the swelling appears normal, no visible pulsations or dilated veins. The swelling moved with deglutition. Upward movement of swelling with protrusion of tongue is absent. Trail sign, the sternal head of the sternocleidomastoid muscle is not prominent. No other visible swelling. On palpation, I stood behind the patient and asked the patient to flex the neck. There was no local rise of temperature, no tenderness. All my inspectory findings were confirmed. 6 into 5 centimeter was the size. Extend superiorly from the thyroid cartilage to 1 centimeter above the sternal notch and laterally up to the anterior border of sternocleidomastoid. Shape globular, surface smooth, margins well defined, and consistency was firm. The swelling moved with deglutition. There were no pulsatile swellings. It wasn't a pulsatile swelling, no thrill, no tracheal deviation, carotid pulsations palpable on both the sides. On Lahey's test, the lateral borders are palpable and rounded. On on examination of the cervical lymph nodes, there was no cervical lymphadenopathy. Percussion, the superior mediasternum was percuss and it was resonant. On auscultation, the upper pole of thyroid, there was no bruit heard. Systemic examination, cardiovascular system, S1 and S2 heard, no murmurs heard. The respiratory system, no vesicular breath sounds, normal vesicular breath sounds heard, no added sounds. Central nervous system, higher mental functions normal, no lethargy or anxiousness. My probable diagnosis is a 35-year-old female, a case of solitary nodular goiter in euthyroid state, which is a benign with a sporadic etiology, without any complication and any retrosternal extension. Thank you, sir.
Yeah, it was okay, nice presentation. But again, like I mentioned, you should have avoided many slides like systemic examination, and you are written as a negative history. There is nothing like negative history. You need to highlight what symptoms she doesn't have. Don't label it as a negative history. There is nothing like negative.
Okay, sir.
So when the time is very short, you need to compel and take out a few of the slides with good information by other slides. Okay. You have mentioned in the inspection, did you highlight about movement with the deglutition?
Yes, sir.
In inspection.
Yes, sir.
Okay, fine. Yeah, can you come back to the examination slides?
Yes, sir.
In the history, you have highlighted that she doesn't have any symptoms suggestive of hypo or hyperthyroidism. Am I right?
Yes, sir.
Okay. Okay, why did you highlight about protrusion of the tongue and movement of the swelling in this particular case? Is it required?
Not required per se, but for completion's sake.
No, you are not supposed to. Yesterday also I have highlighted this.
Sir. Yes.
I am very particular about this. You should have this test only in selected cases. If the swelling is above the thyroid cartilage, midline or paramedian, and a small swelling in a young patient. Okay, so otherwise it is not required in all the given cases like this. This test. Okay. So how did you diagnose that it is a solitary nodule? Why not it is a clinically dominant nodule?
So on inspection, it appeared to be a single solitary nodule, and on palpation, I confirmed with the Lahey's test when, on Lahey's test when I pushed the swelling from the right side and held it from the other hand, so it became more clear that it wasn't that it was a solitary nodule.
No, what I want is, if I ask the question, what is clinically dominant nodule, you people will answer. I want you to learn how to substantiate this same answer whenever you examine a case. If I ask why not it is a clinically dominant nodule, you should have highlighted that, sir, opposite lobe, there are no palpable nodules. This I will confirm by doing a sonography of the neck, confirming that there are no nodules in the opposite lobe. In other words, clinically dominant nodule, you are going to define by mentioning this.
Okay.
You understood my explanation?
Yes, sir. Yes, sir.
Yeah, that's what it is. Okay.
Yes, sir.
Okay. Fine. So what you would like to do for this patient?
Sir, I would like to start with a thyroid function test. Since clinically also the patient was euthyroid, if the test also, if TSH, T3, T4 values are also euthyroid, I would like to carry on with a USG ultrasonography to confirm that it's a benign swelling and not a malignant swelling, by ruling out if there are any microcalcification, microlobulations, taller than wider, and the nodule is cystic, and it's a hypoechoic nodule. And once it's a benign swelling, then there'll be conservative management or medical treatment. If there are any malignant signs present, then
you don't want to have only sonography. You don't want to have a histological diagnosis here.
Yeah. So then, if any malignant signs are present, then
otherwise you don't ask for histological diagnosis.
No.
Not required in all the cases.
If
it is required. Even if sonography, yes, what you mentioned, all the signs of malignancy you mentioned.
Yes.
Even if they are not there, for this particular case, a solitary nodule thyroid, histological diagnosis is a must.
Okay.
Okay, so you will be doing FNAC then and there itself after doing sonography. Okay. Yeah, continue.
On FNAC, according to the Bethesda classification, which would be the first grade would be no a normal thyroid. Second would be any benign.
No, I did not ask. That becomes a lengthy one. Yeah, how do you classify on Bethesda classification? That you will be knowing. Okay, fine. Now it is Bethesda 3 on FNAC, and sonologically all the signs are towards benign, not much findings on a malignancy, towards malignancy. What will you do for this patient? And clinically and biological or biochemically also she is euthyroid.
So anti-thyroid drugs could be started initially, and then she could
euthyroid.
euthyroid.
Biochemically she is euthyroid. Clinically also she is euthyroid.
So then surgically remove the goiter. Surgically remove the thyroid. And
what is that? Surgically remove the thyroid means what
total
is that
total thyroidectomy.
Why total thyroidectomy?
Total or subtotal thyroidectomy. So
why subtotal thyroidectomy? It's a case of solitary nodal thyroid with benign nature and euthyroid status. So what will be the treatment?
If there are no if there are no complications or signs of malignancy, then if one part of the lobule of the thyroid gland can be preserved, then a hemithyroidectomy can be done by removing one part of the lobule and the isthmus.
Okay.
So
if I have given a scenario that opposite lobe is normal, involving only one and a benign nature with euthyroid, the answer should have been hemithyroidectomy on left side, left hemithyroidectomy.
Yes.
Okay. If biochemically she found to be toxic, thyrotoxicosis, with the same clinical findings, what you have elicited, what would have been the treatment?
If she was then total thyroidectomy, sir.
No, lady, hyperthyroidism. Patient has got a hyperthyroidism.
And start on antithyroid drugs initially.
If this patient has got features of hyperthyroidism, what would have been your diagnosis?
Depending on the symptoms, she's showing primary or secondary hyperthyroidism.
This case, she has got a single nodule, and I am giving the picture of thyrotoxicosis.
Toxic solitary nodule.
Toxic nodule or a toxic solitary nodule. Very good. So what will you do that time? Any investigation you will add now?
Yes, radioactive iodine uptake.
Uptake test, thyroid uptake scan. Okay, what it will show?
So if it's a cold, in this nodule, it will show if it's a toxic nodule, it will be hot. That means that there's like more uptake of the iodine. If
so then what is the treatment you will choose if that is a scenario?
Then first on antithyroid treatment before a surgery to lesser the levels of the hormone so that she doesn't go into a thyroid storm while the as a complication of the thyroidectomy. And once the hormone levels are normal, that time she can be taken for surgery.
Other than surgery, you have any other modality of treatment in such a scenario?
Yes, radioiodine capsules, iodine 131 can be used, and it will help to without non-surgically to remove the for the ablation of the thyroid gland.
Okay.
Teachers and my colleagues, I am Shobharno Ghosh, 4th year MBBS student from ESIMC Medical College and Hospital, Joka, Kolkata. Patient particulars. My patient's name is Ms. Chanjoti Devi of age 62. She is a female residing in Bihar who is occupationally a housewife and was admitted on 25th October 2021 and was examined on the following day, 26th October. She presented with a chief complaint of lump in the left breast for the last 6 months. History of present illness. Patient was apparently well 6 months back when she noticed a painless lump in her left breast located in the upper inner quadrant of left breast. It was initially small, 1 centimeter by 1 centimeter, and rapidly increased to the present large size. She has also noticed changes in the skin overlaying the lump in the last 1 month. There is no history of any discharge from any breast or no history of ulceration. She complains of another small lump in her left axilla for last 1 month. She has noticed weight loss over the last 4 to 5 months, although she did not measure her weight. There is no history of lump in the neck or right breast and axilla. There is no history of low backache, shortness of breath, hemoptysis, chest pain, ascites, headache, or convulsions. Past history, no history of diabetes mellitus, hypertension, tuberculosis, no history of surgeries. Menstrual history. She achieved menopause 7 years back, Minaki was around 11 years of age, regular cycles of 30 days, bleeding for 3 to 4 days. She has 2 sons and 1 daughter, but could not specify her age during the pregnancy. All were delivered by normal vaginal delivery. Family history. No history of similar illness in any family member. There is no history of breast cancer in family and relatives. No history of ovary, uterus, colon, prostate cancer in any first or second degree relatives. Personal history, she has a diet of non-vegetarian type. Her appetite is reduced for the last 14 days. Her sleep, bowel, bladder is normal. She has no known allergies to any food or drug. No addictions to alcohol, tobacco, or any other substance. General survey. Patient is alert, conscious, cooperative, well-oriented to time, place, and person. She looks anxious and fearful. Build is average, nutrition average. Her BMI is 21.1 kg per meter square. Pallor, icterus, cyanosis, clubbing, edema was absent. Neck veins were not inverse. Lymph nodes were examined later in details. Her vitals were stable. There is no pain at present. Her Karnofsky score is of 90. On local examination, inspection of the right breast, it was normal. Examination of the left breast. There is asymmetry with the right side. There is a visible lump in the upper inner quadrant of size approximately 6 cm by 6 cm, irregular margins. Overlying skin showed purely orange appearance. Nipple areola complex appeared to be refracted upwards towards the lump. There is no destruction of nipple areola complex and no discharge. Inframammary crease and axilla were normal, no edema of the upper arms. On sitting and leaning forward, left breast does not fall forward symmetrically with the right breast. On supine position, left breast did not fall outward. Right breast falls outward. This is the picture of the lump, and also in the second picture, we can see there is a reflection on the left side of the patient. On palpation, examination of right breast, it was normal. Examination of left breast, temperature was normal in all quadrants. There was no tenderness in any breast. Lump, the site was upper inner quadrant of the left breast, size 72 mm by 60 mm, ellipsoid in shape, hard consistency, rough surface, irregular margins. It was fixed to the skin. It was not fixed to the surrounding. It was fixed to the surrounding breast tissue. It was not fixed to the chest wall. It was fixed to the pectoralis major muscle. Purely orange was seen on the overlying skin. Nipple areola complex, retracted nipple which could not be everted. There was no lump beneath the nipple, no discharge from nipple. Regional lymph node examination. Axillary nodes in the left axilla, single lymph node palpable in the anterior group of nodes, size 1 cm by 1 cm, hard in consistency. Mobility was not fixed to surrounding structures. Other groups were normal. In the right axilla, no palpable lymph nodes. Neck nodes on the left side, there were no palpable lymph nodes. Virchow lymph nodes were not palpable. On right side, no palpable lymph nodes. Right supraclavicular lymph nodes were not palpable. Examination of arm and shoulder, right side normal, left side normal range of motion, no edema of the arm or forearm. Distant metastasis evaluation in musculoskeletal system, no tender points in spine, long bones, pelvis, and skull. Mobility of all joints were normal. Chest examination, bilateral air entry adequate, vesicular breath sounds. Abdomen, liver is not palpable, no free fluid. Nervous system was normal. Systemic examination was normal. Summary. The patient is a 62-year-old postmenopausal lady with 3 children who presented with a left side breast lump for 6 months, which has rapidly increased in size. It is associated with skin changes. There is no nipple discharge. The patient also complains of a lump in the left axilla for last 1 month. There is no history suggestive of distant metastasis. She has no history of comorbidities, no family history of breast cancer or any ovarian, uterine, colon or prostate cancer. On general survey, patient has stable vitals and no significant findings. On local examination, a 72 mm by 60 mm lump felt in the upper inner quadrant, hard consistency, irregular margin with restricted local mobility and skin toxicity.
Soparna, just hold on, because once you say summary, it has to be summary. You cannot again present the case with no family history of cancers of the breast, ovary and other things. And even a local examination, it should not be a repetition of your whole of your presentation in the summary. It will consume a lot of time. It doesn't convey nice things to the listener. Okay.
Oh,
Yeah,
sorry, sir.
yeah. No, it's not. It is a competition. No, you have a limited time. Just because we are listening, and it should not mean that you should present twice the same case.
Yes,
Okay.
I will
So
try to finish it.
coming. No, it's all right. Summary we understood.
So just
So-
one. This is the last slide. I will come to the provisional diagnosis.
Yeah, diagnosis.
So provisional diagnosis: 62-year-old postmenopausal lady with left-sided breast carcinoma with a clinical TNM staging of CT4B N1M0, that is stage 3B according to AJCC 8 edition.
Yeah, here also in the diagnosis, A should not come. It is straight away left CA breast. What is the TNM staging?
Okay, sir.
Okay, straight
Thank
away,
you, sir.
straight away. And you have taken the name of the patient in the first slide itself, which is not acceptable. Yeah, identity should not be revealed. Okay, because
Okay,
I
sir.
saw you have written the name of the patient and the place. Okay, you said that the lump is not fixed to the chest wall. How did you conclude that?
So I asked the patient to for proper exposure, and then in the presence of a female attendant, I examined for chest wall fixicity. I asked the patient to keep both the arms on the side of the hip and keep the hands relaxed. And I tried to move the lump perpendicular and parallel to the direction of the pectoral major fibers, and then it was mobile. So
So
then I asked
pectoralis major fixity means it is to the chest wall.
no, sir, it does not mean.
Then my question was to the chest wall.
Yes, sir. Then I asked the patient to place on the limbs on the hands, and then asked and again tried to move the lump. It was not movable. So
No,
it was not
you
fixed to
please
the-
understand this. What you are describing is to the pectoralis major.
Yes, sir.
What you are describing is to the pectoralis major. Pectoralis major doesn't include the chest wall.
Yes, sir.
Okay, chest wall in relation with the CA breast means it is the intercostal muscles and serratus anterior. You got
Yes,
the
sir.
point. So
yes, sir.
if the lump is not mobile at rest, then we say it is a chest wall fixity or not fixed.
Yes, sir.
Pectoralis major is not included in the chest wall. What you are describing is fixity to the chest wall. Okay.
Yes, sir.
Any confusion?
No, sir. Actually, I
Okay.
wanted to say that in the first place, when I kept the hand relaxed just on the hips, I tried to move and it was mobile. So that indicates it was not fixed to chest wall.
No. If the lump is not mobile at rest without doing anything in the quadrants, or if the lump is lateral to the lateral border of the pectoralis major, where it is lying over the serratus anterior, and do the test for serratus anterior, then comment on fixity to the chest wall.
Okay,
if you
sir.
were placing the hand over the waist and making the pectoralis major to contract and then examining, that means you are checking in relation with the pectoralis major, which doesn't include the chest wall.
Okay, sir. Understood.
Okay, fine. So what is the diagnosis you have made?
So my diagnosis is a left-sided carcinoma of the breast with a clinical staging of T4B N1M0.
Okay, why do you say it is T4B?
So because there is a skin change in the lump.
Okay. Okay. And the lymph node is there, what you have mentioned, single node.
So there is a single lymph node palpable
Okay.
in the.
How do you
left
proceed
axilla.
now? How do you proceed?
So I have completed my clinical examination. I would like to complete the pupil assessment by doing a radiological assessment and a tissue biopsy.
Very good. Very good. Okay. Yeah, tell us what radiological examination and what tissue biopsy.
So for radiological assessment, I will like to do a mammogram of bilateral breast and axilla. And for tissue diagnosis, I will like to do a true-cut biopsy preferably.
Okay, fine. What is the advantage of doing true-cut biopsy?
So the advantages are it gives us a tissue diagnosis and it gives us the status of the hormone receptors, that is ER, PR, and HER2/neu. And it can also tell us about the invasion and the extent.
Okay. Not extent, it will give the
Sorry,
grade of the
invasion.
tumor.
Great,
Yeah,
yes, sir.
grade of the tumor. Fine. How do you do the any metastatic workup, any investigations you would like to do for this case?
Yes, sir. We'll like to do a X-ray of the chest, and if it is for a pleural effusion, and I will also like to do a CT scan of the thorax to see for any thoracic or mediastinal lymph node or any spread. With that, I will like to do an ultrasound of the whole abdomen to look for any liver metastasis or any ascites.
Okay, you have done an ultrasound and there are deposits in the liver. Now
Yes,
you let me know how CA breast spreads to liver.
Sir, CA breast can spread from the lymphatics to the liver. It can spread to the lymphatics to the internal mammary nodes, and then from there it can spread but have a peritoneal. It can have a spread to the mediastinal nodes, and from there to the para-aortic nodes, or it can have a direct peritoneal metastasis.
No, to the liver. How? If it says mediastinal nodes and para-aortic nodes, from there, how does it go to liver?
From the portal lymph nodes.
Portal, how it is connected with the portal system, breast?
Sorry, sir, I am not sure.
You don't know. Okay, fine. Okay. Kishan?
Sir, you can decide.
Yes, sir. Okay. No. Just I thought because it's competition, everything, if it will take a lot of time.
So time we are monitoring, sir.
Okay, fine. I think you should have mentioned if the lymphatics, you have got a subareolar lymphatics, that is plexus of Seppi, and which has got a lymphatics across, which cross the costal margin, that is subrectus sheath plexus of lymphatics. From subrectus sheath of lymphatics, it will go to the lymphatics along the falciform ligament of the liver. From there, it goes to the surface of the liver as a Glison's capsule, which falciform ligament spreads over the Glison's capsule. So this is the lymphatic route. That is why most of the liver deposits in CA breast are surface deposits. This is one of the routes, that is a lymphatic route. The second is hematogenous route. Invariably, in such a situation, they will have a lung deposits. If it is a hematogenous routes, usually they are central deposits, that is a parenchymal deposits. So please remember, these are the two ways which will be asked for undergraduates, for liver deposits in CA breast. Okay. What is the treatment you will take for this patient?
Sir, I will like to do a modified radical mastectomy.
Okay,
along with chemotherapy and radiotherapy.
Is it an early breast cancer, or is it a locally advanced breast cancer, or is it a metastatic breast cancer?
This is a locally advanced breast cancer.
So what is the first treatment for a locally advanced breast cancer?
I will like to go for a neoadjuvant chemotherapy.
Yeah, so that's what you could mention in the examination for this case. Okay, don't mention MRM for this particular case. Okay.
Okay, sir.
Yeah,
yes,
because it's a locally advanced. You said it is A, no? It's B, 4B. It is already involved the skin, and
yes,
he has got a lymph node. So, but best way of treating is in giving a neoadjuvant. What are the drugs used for neoadjuvant?
So we can use cyclophosphamide with atreomycin or epirubicin, and it is 4 cycles followed by taxanes, 4 cycles.
Good, very good. Okay. Then after that, do you assess anything and then plan for the treatment?
Yes, sir. We again assess the tumor size and then we plan for the surgery.
Okay, fine.
Myself, Harshvardhan Singh. I'm a final year MBBS student from Pandit Deenpadhyay Medical, Rajkot. I am presenting the case of Mr. A, who is a 65-year-old gentleman, agriculturist by profession and a resident of Delhi. He belongs to a lower middle class as per modified Kupuswamy scale. He got admitted to the hospital on 28th of October with the chief complaints of discoloration of body with generalized itching since 6 months, loss of appetite and weight loss since 2 months, history of presenting illness. The patient was asymptomatic 6 months back, now presented with a yellowish discoloration of eyes and urine for the last 6 months, anorexia and weight loss for the last 2 months duration. The yellowish discoloration was gradually deepening for about 4 months, and afterwards there was diminution of yellowish discoloration for about 1 month. But for the last 1 month, the yellowish discoloration is again increasing in intensity. The patient complains of itching all over the body. Scratch marks are seen over the legs and forearm. Sleep is altered. Patient is passing clay-colored stool since the onset of yellowish discoloration of eyes and urine. History of passage of black terry stools 2 months back, which has lasted for about 7 days. Sorry. Patient complains of anorexia and significant loss of weight over the last 2 months. Patient complains of a mass in the right upper half of the abdomen for the last 5 months. No history of fever with chills and rigors. No history of prodromal symptoms. No history of vomiting or hematemesis. No history of abdominal distension. No history of headache, seizure, dizziness. No history of exposure to pet dogs. No history of colicky pain. Summary. A 65-year-old gentleman presented with painless progressive jaundice, waxing and waning nature associated with generalized itching, passage of high-colored urine, clay-colored stool with history of passage of black terry stools. He also complains of loss of appetite and significant weight loss. Past history. The patient is diagnosed to have diabetes 6 months back and is on oral medication. No history of hypertension, tuberculosis, or abdominal surgery. No history of any blood transfusion in his past. Personal history, he takes predominantly vegetarian diet, appetite is reduced, sleep is disturbed, his bowel bladder habits are normal. No history of smoking, alcohol, etc. Family history. No history of liver disease or any other malignancy in any of his family members. Now coming to the examination part, the patient is prepared for the examination. The place is warm with the proper exposure of light. The examiner is standing on the right side of the patient, facing the head end. The clothes are removed for the proper exposure, reassurance and relaxing the patient and explaining him the procedure. Now coming to general physical examination. Conscious, the patient is conscious, oriented, moderately built and nourished. Vital signs, afebrile, pulse rate of 80 beats per minute, blood pressure of 140/80 by 80 mm of Hg taken in the right arm in the sitting posture, respiratory rates 16 breaths per minute. The nutritional status is on the normal side. Having performance status of Karnofsky score 90, icterus present, pallor present, clubbing, edema and generalized lymphadenopathy are absent. Scratch marks are seen over the legs and forearm. No signs of liver cell failure. Now coming to the per-abdominal examination, under adequate daylight and privacy, the patient is in supine position, inspected. All quadrants move equally with respiration, umbilicus in midline, shape and contour of the abdomen normal. No localized fullness seen. No visible pulsations are seen. No dilated veins are seen. Now coming to palpation, all the inspector findings are confirmed in palpation. The hands are cleaned, nails are trimmed, and the palms are rubbed to make them warm. Now, by superficial palpation, there is no localized rise in temperature noted over all the quadrants of the abdomen. Tenderness felt over the epigastric region. Now coming to deep palpation, a well-defined globular mass of size 6 cm into 5 cm palpable over the right hypochondriac region and right bulbar region with smooth surface, well-defined margin, firm in consistency and moves with respiration. Lower and medial borders are palpable and side-to-side intrinsic mobility is noted. Liver is not palpable, no splenomegaly, no free fluid in the abdomen. On percussion, dull note over the mass present which is continuous with the liver dullness, no shifting dullness, and liver span of 12 cm at the mid-clavicular line is seen. Auscultation, normal bowel sounds heard, no bruit or venosum over the mass. Per rectal examination normal, no supraclavicular lymph node enlargement. Other systemic examination are seen on the normal side. My provisional diagnosis. This is probably a case of obstructive jaundice due to a malignant pathology, more likely to be a periampular carcinoma. Thank you.
Yeah, Harsha, it was a very fluent and very fast and informative presentation.
Thank you, sir.
Okay, this patient has undergone any surgery in the past in the abdomen?
No, sir. No abdominal surgeries as
In
per
the past.
his past history.
Okay. Can you put that examination slide photograph? Okay, what is that scar in the epigastrium? There is no scar?
No, sir.
Okay, that is not the scar?
No, sir. There is no scar present.
Okay, okay, fine, fine. So at history level, what you felt? Probably this gentleman has the disease. It's all right. You can speak rather than again showing the
Okay,
slides
sir.
to cut down the time. Yeah,
Sir,
at history
yellow is
level, what did you? Yeah.
Yellow is discoloration of the urine.
What
and
is your
eyes,
thinking at
with the
history level? What is your thinking? What is your thinking? What is the disease he has
obstructive jaundice due to a malignant pathology
at history level?
at history level.
That description, what you have given, sometimes it was there, sometimes it was not there, and again it is. So what is that ultimately you wanted to highlight?
It is waxing and waning of jaundice. In
So-
case of periampular carcinoma, it is seen that the central part gets necrosed because of the lack of blood supply, and it gets sloughed off and relieving the obstruction, and thereby the symptoms of jaundice diminish. And
Okay,
this is for waxing.
what is the other type of jaundice one will have in a malignancy? What is the other type of jaundice one can have?
Okay, medical jaundice and surgical jaundice.
No. If this is waxing and waning, what is the other type of jaundice in a malignant cause of obstruction? It's a persistent progressive jaundice, the other variety.
Persistent progressive jaundice seen in case of a carcinoma of head of pancreas.
Okay.
Because
Did you find out whether this gentleman has a history of fever?
no, sir. No history of fever or
What is
reflux.
what is the importance of that? What is the importance of that?
Cholangitis, to rule out to seek cholangitis.
Okay. Has he got history of Malina? Your description has
Yes,
some
sir. Yes,
points.
sir. Passage of black terry stools is there.
Okay. What may be the reason for that?
Sir, the necrosed part which gets sloughed off, it is appearing in the stools. Clotted blood are seen in the stools. That is
Any other reasoning for having blood in the GI system or blood in the stools? One is necrosis of the tumor. Any other reasons?
Yes, sir. Hematochalcia, upper GI bleeding.
Secondary to what? Secondary to what? In relation with this disease. In relation with this
portal
disease.
hypertension causing variceal bleeding.
Why portal hypertension? Why portal hypertension?
So because the tumor can involve the vessels, surrounding vessels like portal vein, superior mesenteric vessels are getting involved in this.
Very good. Okay. Theoretically, yes. Theoretically, yes. That can lead to portal hypertension. And if it has involved only the splenic vein and it has caused splenic enlargement and associated enlarged blood vessels there, what is that portal hypertension called? You understood the question?
Extrahepatic occlusion of vessels leading to splenic thrombosis. And
what is that called? If it is only splenic vein is getting obstructed, causing splenomegaly and portal hypertension, what is that called? That type of portal hypertension?
Sorry, sir.
You understood?
Yes, sir. I understood, but
you don't know the answer. Okay, fine. That is called left-sided portal hypertension. Otherwise called sinistral portal hypertension. Okay, fine. How do you proceed with this case? What you would like to do?
So first I will do the investigation for confirming my diagnosis and for staging the disease and for planning my treatment. So first of all, I will move to liver function test. This in serum bilirubin, I can see rise in conjugated bilirubin. Serum enzymes are raised, for example, alkaline phosphatase, GGT is raised, albumin and globulin for the assessment of liver, and prolonged prothrombin time can be seen.
Yeah, Harsh, just you tell me two important entities in LFT which will help you for the management. Only two. Only two.
Sir, serum bilirubin, prothrombin time.
Bilirubin will be raised definitely because the patient is jaundiced. How it will help you for the management? Prothrombin time accepted because coagulation profile it will depict and it will depict the function of the liver. One more, which should matter for your treatment.
Albumin.
Albumin and prothrombin time. Okay. What other investigation you would like to do?
So after this, I will carry out a USG to delineate the anatomy and the lesion of the gallbladder, liver, pancreas, CBD. It can it tells us about if there is presence of any stones in the gallbladder, or CBD, or in case of periampullary carcinoma or the carcinoma of head of pancreas, we can see a double duct sign, which is dilatation of the bile duct and pancreatic duct. Or
so that is made out in ultrasound itself, or you want to do some other investigation for that?
For confirming, for proceeding, we will carry out the CT scan, which is known as pancreatic protocol CT scan.
Okay, you have found out any other test where you can take a biopsy and do some investigation or to check if it is an ampullary cancer?
So endoscopic USG guided FNAC.
No, ampullary cancer. Can you see that and take a biopsy by some means? In what way you can see that lesion at the ampulla? What test will tell us? We can see the growth and take a biopsy. Endoscopy will not tell
diagnostic
us.
laparoscopy. No.
Laparoscopy, it will be outside. No.
Endoscopy USG.
Not USG. Endoscopy itself with a lateral viewing duodenoscope or upper GA-scope. You can see the tumor and take a biopsy there. Okay. What is that you want to do for this man? What is the treatment?
Sir, if it is a resectable tumor, I will go to the curative surgery. First of all, exploratory laparotomy for confirming my diagnosis, and then proceeding to Whipple's procedure, that is pancreatic duodenectomy. But first of all, I will prepare my patient for the surgery. That is, if he is anemic, hemoglobin less than 10 gram percentage, I will go for preoperative blood transfusion. And for prolonged prothrombin time, I will give parenteral administration of vitamin K for 5 to 7 days. And if it is not working, that means in case of hepatocellular dysfunction, I will give fresh frozen plasma. In case of dehydration, I will give IV fluids or normal saline. And if the person is malnourished, I will go with some parenteral nutrition or enteral nutrition. And for preventing septicemia, I will give him broad spectrum antibiotics like second generation cephalosporin combining with aminoglycosides preoperatively. Then moving to the surgery, the structures which are removed in the Whipple's procedure are whole length of the duodenum is removed up to 10 centimeter, up to 10 centimeter, and distal 40 to 50% of the stomach is removed, and head and neck along with uncinate process of the pancreas is removed. Distal CBD is removed, gallbladder is removed, and associated lymph nodes like pericholedochal, peripancreatic,
what are the anastomosis? 3 anastomosis done after pancreatic duodenectomy?
Pancreatico-jejunostomy having end-to-end anastomosis, followed by hepatico-jejunostomy having end-to side anastomosis, and then at last I will do gastrojejunostomy.
Yeah, very good. You have understood the procedure. You have understood the disease process. Very nice. Thank you. Thank you, Harsha.
Thank you, sir. Thanks a lot.
Everyone. My name is Virishni S., a final year student coming from CMCH, and under the guidance of Dr. Srinivasan sir, I'll be presenting this case. So this is my case. Mrs. X, a 50-year-old homemaker hailing from Sundarapuram, Coimbatore, came to CMCH with chief complaint of swelling in front of the neck for the past 3 years. And moving on to the history of presenting illness, the patient was apparently normal before 3 years. After that, she has noticed a small swelling in front of the neck, which has gradually progressed to the current size. It is insidious in onset, not associated with pain. There is no history of any other swelling, no history of fever. There's no history suggestive of pressure symptoms like dyspnea, dysphagia, change in voice, any history suggestive of Horner syndrome and syncope. And there's no history suggestive of hyperthyroidism like excess sweating, loss of weight in spite of good appetite, heat intolerance, diarrhea, sleepless nights, muscle weakness or tremors, or palpitation or dyspnea on exertion. And there's no history suggestive of hypothyroidism like weight gain, constipation, cold intolerance, easy fatigability, and loss of appetite. And there's no history of metastasis like weight loss, bone pain, pathological fat fractures, cough with hemoptysis, jaundice, abdominal pain, and distension. Past history, there's no history of diabetes mellitus, hypertension, bronchial asthma, TB, epilepsy, or other chronic disease. There's no history of any previous surgery or long-term drug intake, no history of any radiation or any drug allergy. And personal history, the appetite is normal. She consumes a mixed diet, and she does not consume alcohol or any tobacco products. The patient has normal sleeping pattern, and the bowel and bladder habits are normal. And menstrual history, age at menarche at 14 years, regular cycles of 30 days, and menopause at 48 years. And family history, there's no significant family history, similar illness. Treatment history, there's no history of any medication taken relating to thyroid diseases. General examination, the patient is conscious, oriented to time, place, and person. The patient is moderately built and nourished, afebrile, no pallor, not icteric, no cyanosis, no clubbing. Generalized lymphadenopathy is absent, and edema is absent, and there is no eye signs of thyroid disease. And pulse is 80 beats per minute, regular rhythm, normal volume, no special character, no radial or radiofemoral delay, and radiofemoral delay. Blood pressure is 130/80, respiration is 14, and temperature is 98.4. And after obtaining proper consent from the patient with adequate privacy and light, the examination was conducted in the presence of a female attender. So moving on to the examination of neck on inspection. Swelling of size 8 into 6 centimeter, the anterior aspect of the neck. The surface appears nodular, irregular in shape, and the extent is 1 centimeter below the thyroid cartilage to 1 centimeter above the sternal notch. Horizontal extent, it laterally extends beyond the anterior border of the sternocleidomastoid muscle, both sides, and the lower margin is well defined. The swelling moves with deglutition, and no scars are present over the skin. And on stretching, that is extension of the neck, the swelling becomes less prominent. And moving on to the palpation. Palpation was done standing behind the patient by a standard method. The swelling is not warm or tender, and on palpation, the size of the swelling is 10 into 7 centimeter. The borders are well defined, the consistency is firm, and both the lobes and isthmus are enlarged, and nodules can be felt. Swelling extends from 1 centimeter below the thyroid cartilage to 1.5 above the sternal notch, 2.5 centimeter beyond the anterior border of the sternocleidomastoid laterally, and the carotid pulse is felt equally on both sides. Coccus test is negative. There are no enlarged lymph nodes, no bruits heard on auscultation, and the other system examination is unremarkable. Summary: Mrs. X, a 50-year-old female, came to CMCH with a painless progressive swelling in front of the neck since past 3 years, without any symptoms suggesting of hyperthyroidism, hypothyroidism, or any symptoms suggesting of pressure symptoms of metastasis. And on examination, the swelling is nodular and irregular in shape. The size is 10 into 7 centimeter, and it is extending 1 centimeter below the thyroid cartilage and 1.5 above the sternal notch, and laterally extends 2.5 beyond the anterior border of the sternocleidomastoid. The swelling moves with deglutition. The lower margin is well defined, and there are no palpable lymph nodes. So my professional diagnosis would be a case of multinodular goiter in euthyroid state, and probably a benign lesion. Thank you.
Yeah, Virushni, it was a nice presentation, and there was a little modification in the slides, what I could see, like a postgraduate. But yeah, we'll go from diagnosis the other way. Okay, put the diagnosis slide.
Yes, sir.
Yeah, once you say multinodular goiter in euthyroid state, it should stop there only. You need not highlight that probably benign lesion. You need not.
Yes,
if
sir.
you say multinodular goiter, it is understood that it is a benign lesion.
Okay, sir. Yes,
okay,
sir.
if you are suspecting malignancy, straight away you will putting it as probably thyroid cancer. Okay, so you need not highlight in the diagnosis like this.
Yes,
okay,
sir.
okay,
Yes, sir.
fine. In your those photographs with some lines you are drawn, can you put that
Yes, sir.
photograph?
I've tried to.
What is that you wanted to highlight by these photographs?
The first picture was during deglutition. I wanted to, the line is a little bit flat. So I'm trying to demonstrate that since the gland moves up, the prominent thyroid moves up, and the line is a little bit straight and flat. And when the swallowing is at the end stage of the swallowing,
But both the
it
diagrams
will
looks
come back.
alike. Both looks almost the same. There is no difference in
Yes,
the
sir.
tumor and the line
sir.
difference. Okay, you wanted to highlight
It's
that
just a
it is moving with
slight,
deglutition.
yes, sir, yes, sir. Just a slight.
The video was not playing, sir. It's like yesterday. They
Okay,
tried
okay.
it so many times.
Okay, okay, it's all right. Fine. I don't know what sir's opinion is about this fascia. You should not highlight because you cannot check clinically about the fascia. Only muscles can be made to contract, and you can highlight whether it is superficial, deep, or what has happened. In relation with the fascia, it is difficult, both in parotid and both in thyroid also. So don't take this fascia. Sir, what is your opinion, sir? Srinivasan, sir?
Sir, I heard from someone that you cannot contract the fascia, but you can stretch the fascia, but contract the muscle. You can stretch the fascia. That's what I learned it from someone, sir. It's my teaching. That's why she has put it, sir.
Okay, that's what, sir. I wanted to know from you, like, I don't know, fascia, whether we should highlight in the clinical examination. Okay. Yeah, previous slide.
Yes, sir, inspection.
Okay, next slide, next slide. Next slide, next slide. Yeah, you Samir, I saw your, it is non-warm, it is not warmth and non-tender.
Tender, yes,
yeah,
sir.
I have highlighted yesterday this for a thyroid swelling. I think better we should not get these points for discussion.
Okay,
otherwise, you will have questions like where do you get increased temperature in a thyroid swelling? Where do you get tenderness in a thyroid swelling, which unnecessarily will be drawn somewhere else.
Okay,
tenderness and increased temperature for a thyroid swelling, it is better not to have a discussion. Okay. And you cannot conclude that both the lobes are and isthmus are enlarged in the presentation. It is a conclusion drawn at the end.
Okay, sir.
So it is a swelling present on either side of the midline, and you are describing like a swelling.
Okay. Yes, sir.
Okay.
Yes, sir.
Okay. So now you have a diagnosis of multinodular goiter in new thyroid status.
Yes, sir.
Is it right?
Yes, sir.
Is the lower border made out in this patient? Is the lower border?
Yes, sir. Yes, sir. It's made out.
Okay. How do you proceed now?
Now, we have to find the thyroid profile, do test for thyroid profile, TSH, T3, T4, and after confirming the patient is in euthyroid state, we are going to go for the USG guided FNAC of the most dominant and suspicious nodule, and suspicious nodule in terms of whether it is malignant in nature, like hypoechoic state and irregular margins, microcalcifications, increased blood supply, and all those things. And after taking FNAC, and once we've confirmed either it's malignancy or benign, I think in case of multinodular goiter, if we leave this tumor, it might go for hemorrhage or secondary hemorrhage within the nodule, or secondary thyrotoxicosis. And if the nodule grows even more, it might also cause the compression symptoms. So going for total thyroidectomy is a good option, is a better option, I think.
Okay, I did not ask about the treatment. No, how do you proceed? Okay, fine. Any other investigation before you plan surgery for this lady?
Investigations, thyroid profile, and looking for the recurrent laryngeal nerve, sir, whether it's
okay, ideally want to do
because usually we have to confirm whether there is a lesion that has occurred early or not, and whether it's patent.
So how do you find out that laryngeal nerve involvement? What is that? Any
indirect
investigation
laryngoscopy
or direct laryngoscopy to see the movement of the vocal cords?
Yes, sir.
X-ray neck, you want to have a chest X-ray and X-ray neck?
Yes, sir. Yes, a chest X-ray neck to find whether it's retrosternal goiter, and whether the trachea is in the normal position or not, and mostly the extent of the
what position of what neck X-ray will give us about the status of the trachea in this case?
So,
what neck X-ray? What neck X-ray will give us the information about the status of the trachea?
The Anteroposterior plane X-ray can give you the status, the position of the trachea.
Okay.
And,
can you make out deviation also in the anterior posterior?
Yes, we could make it
fine.
out. Yes.
What is that complication you expect after doing surgery for this case pertaining to trachea?
It can undergo hematoma, that is hemorrhage, and the
No, please
edema of the
understand.
laryngeal.
Please understand. Pertaining to trachea, what complication you expect for this case? Which I have discussed yesterday when the thyroid case was presented.
If it is a long-standing multinodular goiter, the tracheal cartilage might undergo weakness.
Very
So
good.
if you remove the thyroid cartilage, thyroid gland, there is the loss of support for the trachea. So it's tracheomalacia. Tracheomalacia.
Very good. This is the lady likely candidate for having a tracheomalacia. That is bilobar disease, larger gland, longer duration.
Yes.
Okay. So she is a candidate for tracheomalacia. When do you expect tracheomalacia after doing surgery? Is it when the tube is in place or after extubation?
After extubation.
How it is being treated? Any idea?
Not sure about that.
Okay, fine. It needs immediate re-intubation and then plan, if required, at the most tracheostomy, if required.
Yes.
Re-intubation is very important.
Yes,
How do you know it is a tracheomalacia on table as a surgeon?
Cocker's test is the on table, sir.
Yeah, on table. I knew you will mention Cocker's test, and yesterday we have highlighted that you are not supposed to do that test bedside.
Yes, sir.
If you attended the class yesterday.
Yes, sir, but you told like if it is bilaterally involved.
On table, how will you find out that this patient has got tracheomalacia?
On table. I'm not sure, sir.
To say soft, it is softening, no? It is softening of the trachea.
Softening. Okay.
To say
Yes,
soft,
sir.
what the surgeon should do?
To palpate or...
To palpate, yeah, you need to palpate the trachea after removing the thyroid. If you want to palpate the trachea after removing the thyroid, can you appreciate the softness on table?
Yes, sir. Yes, sir. I think you
How
can.
Can you appreciate there is a tube inside, endotracheal tube, because patient is under anesthesia.
Okay, sir. After removing the tube, or
means after closing everything, remove tube and then, or do what? Okay. What I wanted, you ask the anesthetist to deflate and pull the tube little up and then palpate the trachea.
Okay. Okay. Sir.
If the tube, then decide about extubation or predicting problems of tracheomalacia in the post-op period. Okay.
Yes, sir.
Okay. Why do you say it is a total thyroidectomy for this patient?
Because sometimes the multinodular goiter might recur, sir. So if there is a risk of recurrence, doing total thyroidectomy is better, because if we do a subtotal thyroidectomy or something like that, and if it recurs, we lose the plane of dissection, and there is fibrosis and adhesion.
Okay. Tell me other two complications of total thyroidectomy.
Recurrent laryngeal nerve palsy, sir, and mainly parathyroid removal. If you remove the parathyroid gland, hypocalcemia.
Points to identify parathyroid on table.
Parathyroid on table.
How many parathyroids are there?
For 2 pairs of superior and 2 pairs of inferior parathyroid glands.
So how are they being identified on table by surgeon?
It's yellowish to brownish nodule present at the posterior surface of the thyroid gland, sir. So I think they might check for...
How will you differentiate between a fat globule and a parathyroid? Fat globule also looks alike.
Yes, sir. Yes, sir.
Yeah. That's why it's called golden yellow color. Parathyroids are called
golden yellow color.
Golden yellow color. Any idea how are they differentiated from fat and? Okay, fine. If a person develops hypoparathyroidism after total thyroidectomy, when do you expect them to develop?
Probably after a week or something. So I'm not.
Okay, fine.
I am Maya Sunder from Coimbatore Medical College. Under the guidance of Dr. Srinivasan sir, I am going to present a case today of breast lump. My patient was Mrs. ABC, 56-year-old female, a factory worker by profession and resident of Coimbatore from upper lower social economic class, came with the chief complaint of lump in the left breast for the past 2 months. History of presenting illness. The patient was apparently normal 2 months ago. Later, she noticed a lump in the left breast while bathing in the upper outer quadrant of the left breast. She noticed the swelling 2 months ago when it was small in size, but rapidly progressed to the current size in the past 1 week, along with the recent onset retraction of nipple. There are no complaints of pain, and no history of fever, and no history of nipple discharge. There's no history of trauma, no history of weight loss or loss of appetite. There's no history of any swellings in the contralateral breast. There's no history of swellings in both the axilla or the neck. No history of breathlessness, cough, or chest pain present. No history of pain in the back, shoulders, hips, or any other long bones. No history of abdominal distension, pain, or jaundice. No history of headache, seizures, dizziness, or vomiting. Past history. History of diabetes mellitus for the past 6 years and is on medication. No history of irradiation, no history of intake of oral contraceptive pills or hormonal replacement therapy. No history of similar complaints in the past, and no history of any other medical comorbidities or any surgeries done. No history of biopsies or surgical intervention of the lump. Personal history, no history of smoking or alcohol consumption or any other addictions. No history of loss of appetite and consumes mixed diet. She has an undisturbed sleep pattern and a regular bowel and bladder habits. Family history, her mother passed away because of breast cancer at the age of 60. No history of ovarian, colon, prostate, pancreatic, gallbladder, cancers, and melanoma in the family. Menstrual and obstetric history. Menstrual history. She attained menarche at the age of 13, attained menopause at the age of 50. Her menstrual cycles were regular and there were no postmenopausal complaints. Marital history, married at the age of 24 years and had a first child at the age of 26 years. It was one male child, alive and healthy, born at full term, normal vaginal delivery. He was breastfed for the first 6 months and there's no history of abortions. Summary, and a 56-year-old postmenopausal diabetic woman with complaints of painless lump in the left breast for 2 months, along with rapid progression and retraction of nipple present. Has a history of breast carcinoma in her mother and most likely malignant etiology with no symptoms of metastasis. Physical examination, general examination. Patient is conscious and oriented to time, place, and person. Comfortable at rest and afebrile. Moderately built and nourished, no pallor, no generalized lymphadenopathy, not ectric, no clubbing, no cyanosis, no pedal edema. Oral cavity shows no staining of teeth. Neck, limbs, and spine appear normal. Konski score of 90 and ECOG of 0. Vitals appear normal and the BMI is of 31.1 kilograms per meter square. Local examination of the breast, inspection after getting proper informed consent from the patient and exposing till the waist level. The examination was carried out with adequate privacy and lighting. Patient in sitting position with arms by the side. The right breast appears normal. The left breast appears bigger than the right breast. Skin over the left breast is normal. Nipple retraction is present. No nipple discharge seen during examination. Arms raised above the head portion. Left nipple is at the normal portion. Nipple retraction can be seen. No evident dimpling or puckering of the skin is seen. With bending forward, both the breasts fall forward equally from the chest wall. With the hands on the hip portion, the swelling becomes more prominent. Areola is of normal size. No cracks or fissures noted. Inspection of the upper limb and shoulders is normal. Movement of the shoulder joint in full range and is painless. Axilla and supraclavicular region does not show any fullness. Local examination of both the breasts, palpation. It is done in semi-recumbent position. Inspectory findings are confirmed by palpation. Right breast is normal. Left breast, no warmth, not tender. A solitary, hard, not tender lump, about 4 x 4 centimeters, palpable in the upper outer quadrant, extending to the lower outer, behind the nipple areola complex, extending from 8 to 11 o'clock position, irregular surface and well-defined margins. Nipple retraction present. Skin over this lump is pinchable. The lump is fixed to the surrounding breast tissue. It's not fixed to the pectoralis major, serratus anterior, or the chest. No nipple discharge is seen. Examination of the regional lymph nodes done in sitting position. Right-sided axilla shows no palpable lymphadenopathy. Left-sided axilla is a single 2 × 2 centimeters mobile hard lymph node was palpable in the anterior axillary tube. Bilateral supraclavicular fossa shows no palpable lymphadenopathy. Systemic examination, abdomen is soft, no tender, no organomegaly. Respiratory system is normal. Cardiovascular system is also normal. CNS symptoms is also normal. Rectal and vaginal examination done and it's normal. Skeletal system also shows no abnormalities. Summary, Mrs. ABC, 56-year-old postmenopausal diabetic woman, has a hard lump in the left breast for the past 2 months. Positive family history of breast carcinoma. On examination, hard lump of 4 × 4 centimeters palpable in the upper outer quadrant and lower quadrant of the left breast, has nipple retraction and is fixed to the breast tissue but is not associated with the skin or muscle involvement. A single palpable axillary lymph node in the anterior axillary fold is felt. My provisional diagnosis is a case of carcinoma left breast with a TNM staging of T2, N1, M0, stage 2B of early breast carcinoma. Thank you.
Yeah, it was a very fluent and a nice presentation, and I'm happy with that summary slide.
Thank you, sir.
Really, yes, that is how the summary slide should be. It
Thank
should
you,
not
sir.
be a repetition of the presentation. You have conveyed everything in that single slide. Okay, yeah,
Thank you, sir.
good presentation. Is the lump seen on inspection? Not seen.
So it's like a breast fullness, so we can't say it is a lump. The
It is
left
not
is
seen. But somewhere I heard your presentation, I saw in the slide mentioning that after putting the hand over the waist, the lump became prominent. That's what you have presented somewhere. Don't go back. I remember your presentation, so you should know your presentation.
Yes, sir. I think it's present when you put the hand on the hip position.
Exactly. That's what you highlighted. So did it happen like that?
Sir, it felt like when I was focusing on the lump, probably I felt like that.
Because nowhere we teach you people that to make the lump prominent, do this like this test.
Yes, sir.
Okay.
Sorry.
Yeah, probably on inspection, absolutely, except the breast appears bigger than the opposite side. You
Yes,
don't
sir.
have any other findings, which you did not highlight anywhere in the inspection. The left breast appears bigger than the right, with no obvious visible lump.
Yes, sir.
Yeah, that should have been the inspectory finding.
I had just mentioned that the left breast was bigger than the right breast.
Okay.
If
If I ask you to give a diagnosis,
okay, sir.
Please understand this question. If
Okay,
I
sir.
ask you to give a diagnosis, just looking at the breast, what will be your diagnosis?
I would have 2 to 3 differential diagnoses in my mind, sir.
Okay.
First, the patient's age is postmenopausal.
No, don't. I'm very clear. Looking at the breast, knowing that history,
Okay.
looking at the breast, what would have been your diagnosis? Because my finding or your finding is left breast appears bigger than the right breast.
Yes, sir.
With no obvious visible lump.
Yes, sir.
So what would have been your diagnosis or thinking?
With early breast carcinoma, sir.
Why breast should appear big if it is early breast cancer?
Because compared to the right breast,
whole breast appears big. So what should be your thinking? If the whole breast appears big,
mastitis it could be a case of mastitis.
What I wanted from you, the lesion occupying whole of the breast. What is that disease which can occupy whole of the breast and gives a big breast appearance? What is that disease in the breast?
Whole breast.
Phylloids tumor. What I wanted the answer was a phylloids tumor.
Okay. Okay, sir.
You got the point?
Yes, sir.
Whole breast will be enlarged.
Mm.
Otherwise, absolutely, there won't be any signs.
Yes, sir.
Only you will be able to appreciate the lump when you palpate the breast.
Yes, sir.
Okay, fine.
Okay.
So you have diagnosed a malignancy of the left breast because
Yes.
of the lump size and whatever the description you have given. Okay, how do you proceed now?
I'll go for investigation, sir. First, I would like to confirm my diagnosis, and then I would like to know the extent and whether I'd like to know whether it has metastasis or metastasis other locations. And then I would like to see if my patient is ready for my treatment. And so first, I'd like to do triple assessment. So I'd like to do clinical assessment, histopathological assessment, and a radiological assessment. And in
second is radiological, second is radiological, third is histological.
Okay, sir.
Huh? Okay. Yeah,
okay,
mention radiological, what test you want now?
Radiological, I like to do USG axilla and sonomammogram, and USG abdomen should also be done. And in radiology, and then in histopathological, I like to do group.
If you are talking about triple assessment, don't include USG abdomen here. That is a metastatic workup investigation.
Oh, okay, sir.
Your aim was triple assessment. Clinically, you are done. Radiological is sonography, sonomammography, and X-ray mammography. Then histological is doing FNAC of both the areas, primary and regional. Okay, that is triple assessment.
Okay.
Fine. Okay, now. So now you have done these investigation. FNAC is ductal carcinoma in the primary, and FNAC of the node is positive for deposits. Any other metastatic workup you want to do for this lady?
I like to check for liver mets and bone mets. Sir.
You mentioned no what test you want. What is
I like to do USG abdomen and X-ray long bones.
Oh, all whole body X-rays you will do.
Ribs,
X-ray chest. Long bones you want to do.
X-ray chest. If the patient would complain of any symptoms in any particular long bones, or I'll go for X-ray chest. Sir.
Okay, X-ray chest or chest CT also is accepted. Okay. CT chest. Okay. Now what will you do? FNAC, no other deposits anywhere in the body. FNAC of the primary is IDC. Node is deposits positive. What will be your treatment?
So in this patient, I would recommend to go for MRM, sir, and modified radical mastectomy.
Okay. Any role for BCS for this patient because your diagnosis is early breast CA?
So in this patient, I would mention about BCS, sir, but then this patient's pendulous breast would not be a ideal treatment for BCS because of the radiotherapy won't be proper, and the breast to tumor to breast size ratio is also huge. So I would take that into consideration.
This lady insists that she wants to have her breast. Okay,
then
your reasoning is fine. Your reasoning is fine, but she wants to have breast, and your plan is BCS. Anything else you can do other than doing BCS for the affected breast, so that it will be cosmetically better for this particular patient.
Doing BCS, what we can do, you're asking?
Yeah, cosmetically also she should have a nice
We can make a flap.
Keeping that in mind, and so that even a radiotherapy is acceptable for her after doing surgery. Anything else can be done.
We can remove the extra breast mass.
Okay, on the affected side or the opposite side?
The affected side.
Affected side anyway, you'll be doing wide local excision with axillary dissection.
Why would we remove now?
Okay, fine. What will you do for the, if it is a point is BCS, what will you do for the axilla in this case?
Axillary dissection, sir.
Axillary dissection. Okay, fine. The other option, what you have mentioned, the MRM also is we accept for undergraduates. That is the best way of managing breast malignancies. More so in this particular patient where there is a family history. Mother has suffered.
Sir.
What do you expect pertaining to HER2 status for this lady?
HER2 status probably positive, sir.
Probably positive. What will be her BRCA if you do a gene examination? What will be if there is a family history positive?
Sir, in the history, family history, we had no other BRCA 1 or 2 history in the families except her mother, sir. So
Okay.
BRCA 1 or 2 is pretty rare. It would probably be negative, sir.
Probably negative. Okay. Any adjuvant treatment she may need?
So chemotherapy, because according to the hormonal status, we can treat her, sir. And chemo and radiotherapy, chemoradiotherapy can be done.
Okay.
Good evening, everyone. I'm Subicha TS, a final year MBBS student from Coimbatore Medical College. I'm presenting this surgical case under the guidance of Dr. Srinivasan. My case is a 56-year-old male from Ukkadam, Coimbatore, who is a driver by occupation, and he was examined on 23rd October 2021. He presented with the chief complaints of swelling in front of the neck for the past 3 years. Sorry, sir. History of presenting illness. The patient was normal before 3 years, after which he developed a small swelling on the anterior aspect of neck on the right side while taking bath. It has slowly increased in size to reach the current size of 5 into 5 centimeter. It is insidious in onset, progressive in nature. It is not associated with any pain. There is no history of fever, no history of any other swelling. There was no history suggestive of pressure symptoms like no history of difficulty in breathing, no history of difficulty in swallowing, no history of change in voice, no history of syncope, no history suggestive of Horner syndrome. There was no history suggestive of hyper or hypothyroidism. He also had no history of bone pain, no history of fractures, no history of headache or seizures, no history of cough with hemoptysis, no history of dyspnea on exertion. Past history, there were no history of similar complaints in the past, no history of irradiation, no history of previous surgery, and is also not a known case of diabetes, hypertension, asthma, epilepsy, tuberculosis, or ischemic heart disease. Treatment history, he is not on any medication and there is no history of any known drug allergy. Personal history, consumes mixed diet, no history of intake of brassica family of vegetables, history of taking iodized salt, normal bowel and bladder habits, normal sleep pattern, not a known smoker. He consumes alcohol, 30 ml per day of brandy for the past 20 years. Family history, there is no history of similar illness in the family members. A summary of history, a 56-year-old gentleman from Ukkadam, Coimbatore, presented with complaints of swelling in front of the neck for the past 3 years. It was insidious in onset, slowly progressing to the current size with no symptoms suggestive of hypo or hypothyroidism. There were no pressure symptoms and there was no significant past personal or family history. General examination, the patient was conscious, cooperative, and oriented to time, place, and person. He was moderately nourished, afebrile, no pallor, not icteric, no cyanosis, no clubbing, no pretibial or pedal edema. Skin is normal on touch, eyes are normal. Vital signs, temperature was 98 degrees Fahrenheit, pulse rate 71 beats per minute, regular rate and normal rate, rhythm and normal volume. Blood pressure 110 by 80 millimeters of mercury measured in the left upper limb in sitting posture. Respiratory rate 17 breaths per minute. Local examination, after explaining the procedure and getting consent, the patient was adequately exposed from chin to nipple in the sitting position and examined in a well-lit room. Inspection, I inspected the swelling standing in front of the patient with the neck slightly flexed. Slightly extended. 5 into 5 right-sided swelling, which was globular in shape, was found in the front of neck. The skin over the swelling appears to be normal. No scars are seen. Surface appears to be smooth. Margins are well-defined. Moves upward on deglutition, and lower border of the swelling is clearly seen. Tracheal position seems to be in midline. Palpation, inspection findings are confirmed. A single nodule of size 5 into 5 centimeter is felt over the right lobe and isthmus of the thyroid gland and extends 1 centimeter below the upper border of thyroid cartilage, 6 centimeter and below 6 centimeter above the sternal notch, and laterally it is 1 centimeter from the anterior border of the sternocleidomastoid. And medially it almost touches the midline, and rest of the gland was not palpable. Skin is pinchable, surface is smooth, firm in consistency, margins are regular and well defined, lower border is palpable 5 centimeter above the clavicle, plane of the swelling deep to deep fascia. Carotid pulsation on the left side is felt against the upper border of the thyroid cartilage, and on the right side, it is displaced posterolaterally. No palpable thrill or pulsations present. Trachea is in midline and no other swellings are present. The measurement of the neck at the most prominent part of the swelling is 39 centimeters. Examination of lymph nodes. No palpable lymph nodes are seen in the neck region. No eye signs were present. Percussion, a resonant note was heard over the manubrium sterni. Auscultation, tracheal gush of hair was heard over the midline and no bruit was heard. Other system examination was normal. Diagnosis, this is a case of solitary thyroid nodule, which is clinically euthyroid. Thank you.
Yeah, can you put the clinical photographs, that photograph, clinical photograph?
Yes, sir, sure, sir.
Can you show me the thyroid cartilage in this? Just with a marker, can you show me the thyroid cartilage? Where is the thyroid cartilage?
So can you see my arrow, sir?
Yeah, I am able to see. Show me thyroid cartilage.
So the upper border must be right around here.
Will it be at that plane where the jaw joins the neck? There you will get the hyoid bone. It looks lower down. Bring that cursor down. Cursor down, down, little more down, little more down. Prominence is down, no? Prominence is down.
Sir, I thought that was a thyroid notch, so
Yeah, prominence, thyroid notch, you will get there only, no? Prominence.
Yes, sir. Thyroid
for me, clinically, it looks like it is not over thyroid cartilage. It is little looks higher up, almost near the junction of jaw and the neck. Okay. Was it moving with the deglutition?
So yes, sir, it moved with deglutition, sir.
Okay. Did you try movement with the tongue protrusion for this particular case? Because it looks high up and in the paramedian region.
Sir, I did, sir. It did not move on protrusion of tongue.
Yeah, you are not mentioned that in the slide. Probably
not to mention it. I removed it now, sir.
Yeah, I knew that you removed that. I knew that because of the size. Probably I may question. That is why you removed that movement with the protrusion of the tongue. Okay, yeah, I could guess that. Okay, fine. Anyway, fine. So you have diagnosed it. It looks something, sir. Srinivasan, sir, for you, I don't know. It looks something unusual for a thyroid swelling.
Yes, sir. This patient actually came and the photograph was taken by a PG and he took it in a different way. When she examined, the patient was about to get discharged, so they took it in an urgent way.
Okay.
But it looks on the little lateral aspect and upper, and also on the upper side, sir.
Up, sir. Yeah. Maybe thyroglossal cyst we may fit into the diagnosis. Only point against is size and the age. Size and the age. But position looks, if it moves with the deglutition, it goes maybe more for thyroglossal cyst than solitary nodule. Fine. So how do
we operated, sir? I will tell her what I said after she finishes.
Okay, sir. Okay, so your diagnosis is solitary nodule thyroid in euthyroid status. Okay, how do you proceed now? For me, it looks something unusual for a thyroid swelling. Fine.
Okay, sir.
How do you?
Sir, I'll take the general non-specific investigations for anesthetic.
No, don't say, lady, non-specific. Don't say non-specific. Okay, everything is specific and everything is important for a surgeon.
Okay, sir. Sir, first I'll do the. Okay, sir. First I'll do the thyroid function test. If it is biochemically euthyroid, I will proceed with the ultrasound of the neck. In the ultrasound of the neck, I'll look for signs of malignancy, if any. If it is a solid or a cystic swelling, if there are any nodes that are present, and then I will proceed with the USG guided FNAC. Along with that, I'll also take a chest X-ray.
If your suspicion is for malignancy, how do you substantiate in this particular patient? How do you substantiate? If you have a suspicion of malignancy,
Sorry, I am not suspicious of You're asking about the USG findings in for malignancy.
No, I'm not
sir.
asking USG. That he will mention all of you because you people are now well versed with the USG findings of malignancy. I know that.
Okay, sir.
Okay. So this patient, if I say, yeah, keep a suspicion of malignancy, what are the points?
Sir, mostly there'll be in the history pressure symptoms. He present with pressure symptoms like
this patient, whatever your patient is male.
Yes, sir. Male.
Patient
He's
is
an older
male.
patient.
Elderly patient. Presenting as a solitary nodule.
Presenting as a solitary nodule.
Yeah, everything fits into keep a possibility of malignancy.
Malignancy. Okay, sir.
Okay. Male patient itself is a risk factor for thyroid diseases.
Okay,
unless
sir.
it is thyrotoxicosis, where malignancy chances are less.
Yes.
Okay. If you say you are suspecting malignancy, what is the commonest malignancy you can come across in a solitary nodule?
Sir, papillary carcinoma. Malignancy is papillary carcinoma.
Malignancy. What else you will examine if you are keeping a suspicion of papillary carcinoma?
Sir, in the FNAC, I might get it as a follicular adenoma.
What else you will examine if your suspicion is papillary carcinoma? What else you will examine?
Sir, I'll examine for the neck nodes.
Neck nodes will examine.
Neck nodes.
Okay. Very good. Okay. Okay, fine. What will you do? If it comes as papillary carcinoma thyroid, FNAC, what will you do?
Sir, only for a few exceptional cases, like very low risk when the size of the nodule is less.
This case, what will you do?
Okay. So then I'll do a total thyroidectomy, sir.
Substantiate. Why total thyroidectomy?
So because papillary carcinoma has an intrathyroid extension, may have an intrathyroid extension, and also local lymph node in the neck may be positive. So
no, don't bring neck nodes. Substantiate for total thyroidectomy. Why do you want to remove the opposite innocent lobe for this patient? Substantiate.
So intrathyroid extension might be present.
Okay, it is not called extension. They can have an intrathyroid lymphatic spread.
Lymphatic spread.
Yeah, because thyroid has got intrathyroid lymphatics.
Papillary. Yes, sir. And usually papillary cancer has a multicentric origin. So
exactly. These are the two important reasoning for doing total thyroidectomy.
Okay.
And third, in this particular patient is male, very high chances, and is an elderly patient.
Elderly patient.
Exactly. Okay. So all total thyroidectomy. After doing total thyroidectomy, what do you do for the papillary cancers?
Sir, I will look for residual disease or metastasis using a radioiodine study.
Very good. Then what do you do if there are no residual disease or no metastatic deposits, or there is a small amount of gland in the neck? So anything you want to do that then and there itself?
Sir, I'm not. So there is residual disease you're asking, or
yeah, if there is a small residual disease left or found on nuclear scan, anything will be done then and there itself.
Sir, radioiodine therapy can be given. A single dose iodine 131 ablation can be done.
Okay, what will you do for the nodes if clinically and radiologically, if there are no nodes for this patient?
Sir, if there are no nodes, total thyroidectomy is enough. But if the nodule is more than 4 centimeters, as in my case, I can do a prophylactic central neck dissection.
Fine. Sir.
Patient, Mrs. ABC, is a 55-year-old female who's a homemaker by occupation, comes from Coimbatore with the chief complaints of prominent swelling in front of the neck since 3 years. This is the patient. The patient was apparently normal 3 years ago when she incidentally noticed a swelling in front of the neck. The swelling was insidious in onset and progressive in nature, and it was rapidly increasing in size since 1 year to attain the present size. It is associated with difficulty in swallowing since 3 months back, and there is a history of pain in the swelling since 3 months, which is dull aching in nature. It is associated with hoarseness of voice since 1 month. There is no history of difficulty in breathing, but the patient complains of a sensation of choking present on flexing or turning the neck. There is no history of bone pain, no history of cough and hemoptysis, No history suggestive of hypo or hyperthyroidism, and no history suggestive of Horner syndrome. Presently, the patient is not a COVID-19 positive. The past history, there are no similar complaints in the past. No history of previous exposure to radiation. There is no history of previous surgical intervention. No history of diabetes, hypertension, and TB. There is no history of epilepsy. The patient is not on any medications, and there is no history of any drug allergies. In family history, there are no similar complaints in the family, and no history suggestive of thyroid disease in the family. Menstrual history, the patient had attained menopause 10 years back. Personal history, the patient is on a mixed diet and consumes iodized salt. No excessive consumption of brassica group of vegetables. Appetite is normal and sleep is adequate. Bowel and bladder movements are normal, and there is no history of smoking and drinking. For summary, a 55-year-old woman has presented with the complaints of swelling in front of the neck since 3 years, suddenly increasing in size for 1 year, and is associated with dull aching pain, dysphagia, hoarseness of voice, and it probably could be a malignant swelling arising from the thyroid. My general examination, an informed consent was taken from the patient, and the examination was done in the presence of a female attendant in adequate natural light and exposure of neck. And I was in the eye level of the patient when examining swelling. The patient was moderately built and nourished. She is in comfortable sitting position, conscious, well-oriented time, place, and person, and responds verbally. No signs of Horner syndrome on examination. There is no pallor. The patient is not icteric, not cyanotic. There is no clubbing, no generalized lymphadenopathy, and no edema. On inspection, I could see a prominent swelling, approximately 12 by 12 centimeters in size, in front of the neck, just more on the left side. It looks hemispherical. And on inspection, I could see the superior and lateral margins, but the lower border of the swelling was not appreciable. The skin appears stretched and hyperemic. The surface appears bosselated. There were no obvious engorged veins, and the swelling had restricted mobility on deglutition. Pemberton sign was negative, and there were no surgical scars or sinuses. On palpation, the inspectory findings were confirmed. I could feel the bosselated surface with distinct margins. It had a variegated consistency with hard and soft borders, nodules, and the lower border of the swelling is palpable. The course of the trachea was not appreciable. The skin over the swelling was pinchable in the peripheries, and it was not pinchable in the center and summit of the swelling. The lymph nodes were not appreciable on the left side and not palpable on the right. The carotid pulsation is felt on both sides equally. No pulsation or thrill on the thyroid gland. On auscultation, there was no appreciable bruit on the thyroid gland. Systemic examination was normal. My provisional diagnosis is it's a malignant thyroid swelling in euthyroid state. Thank you, sir.
Yeah, can you put the clinical photograph? That looks
Yes,
a beautiful photograph.
Yes, sir.
Yeah. Okay. You have mentioned that movement at the deglutition is restricted.
Yes, sir.
Okay. What may be the reason? Even though it is a thyroid swelling, you said movement of the.
So the swelling could have gone. Could be extracapsular spread to the sternocleidomastoid or to the trachea, and it could have been attached.
Yeah. Once any thyroid swelling comes out of the deep investing cervical fascia,
Yes,
or
sir.
if it comes over the chest, or if it gets infiltrated, the movement becomes nil, or it is restricted. Movement is
Yes,
a
sir.
deglutition. Yes, very good. Is it coming over the chest wall?
Sir, on inspection, I could not see the lower border, sir.
No,
But I could.
coming over the chest wall, over the sternum.
Yes, sir. It is coming over the sternum.
How do you explain this for a thyroid swelling? Otherwise, thyroid swelling should go into the mediastinum.
Yes, sir.
Yeah.
Sir, it is. Sir, since it's a very large enlargement anteriorly, it could have.
Again, it is an infiltration of the deep cervical fascia, because the limitation of deep cervical fascia is attached to the inner aspect of the sternum and the clavicle, nanoframe sternum and the clavicle. So if that fascia is infiltrated, then the thyroid swelling starts growing over the chest wall.
Yes, sir.
Okay.
Yes, sir.
So that is a point in this particular case.
Yes, sir.
Okay. Patient, you said history in the patient has got hoarseness of voice.
Yes, sir.
How do you explain that?
Sir, due to the involvement of recurrent laryngeal nerve.
Recurrent laryngeal nerve. looking at the picture, what you have shown, is it likely to have stridor or is it likely to have hoarseness in this particular patient?
So there could be both, sir.
There could be both. Has she got stridor?
Not normally, sir, while turning the neck or...
no, this patient, has she got stridor?
No, sir. No, she doesn't have stridor, sir.
She doesn't. So what is the inference of this? She has hoarseness, but doesn't have stridor.
Yes, sir. So there might not be tracheal infiltration or compression, tracheomalacia.
Where can you expect tracheomalacia in this patient, even though gland is used?
Sir, yes, sir. It's long-standing swelling. So I could expect tracheomalacia, sir, but it's actually unilateral swelling. So.
Yeah, one is unilateral. Second, there is a possibility of malignancy. Malignancy will not cause tracheomalacia. It will cause tracheal infiltration. Tracheomalacia is more common in benign diseases. Benign diseases. If you are talking about benign and malignant.
Yes, sir.
Okay, here infiltration is more likely than tracheomalacia.
Okay.
Okay.
Okay, sir.
Okay. You said surface is lobulated.
Bossulated, sir. Yes, sir.
Bossulated. Okay. When do you say a surface of a swelling is bossulated?
So when it's uneven.
Then nodular and bossylation are same. That is also uneven surface.
Sir, it's a consistent surface. Nodular, we can feel the nodule separately, sir. But
here also you are feeling something, but bigger size. So what is the criteria to say that it is bossulated and a nodular?
Sir, I'm not sure.
Okay, if it is more than 3 centimeter, we label them as lobulated surface.
Yes, sir.
Anything less than that with a similar surface, that becomes nodular. Third is smooth, where both of them are not there.
Yes, sir.
Okay.
Okay, sir.
Okay, fine. So what do you want to do for this lady?
Sir, first I will do thyroid function tests to confirm whether the patient is euthyroid.
And one more, in the diagnosis, what you have put malignant thyroid swelling in new thyroid status.
Yes, sir.
I don't know, Sir Srinivasan, sir, just let me know whether will you accept this. When your diagnosis is going to be a malignancy of the thyroid, you need not mention the physiological status of the gland.
Yes, sir.
Because it is very unlikely to have malignancy in a thyrotoxic patient. So we don't otherwise we expect all thyroid anatomical and physiological status.
Yes,
but when you clinically have a suspicion of cancer, that is malignancy of a thyroid, physiological status need not be mentioned.
Yes,
so
sir.
in this particular case, straightway, if we can put the diagnosis of carcinoma thyroid also is acceptable. Sir, what do you say, sir? Srinivasan, sir?
Correct, sir.
Yes. Okay. So how do you proceed now?
So yes, sir. I'll first do the thyroid function test, and then sir, I'll do the ultrasound of the neck. To confirm the thyroid scoring and whether lymph nodes are present or not, as I could not clinically palpate any lymph nodes. And I will also take an X-ray of the neck and chest to see whether there is mediastinal asternal extension and to see whether the deviation of the trachea or any compression of the trachea is present. Sir, since it's a large swelling, we could do a CT also for the swelling, sir.
You should mention, I was waiting for that, okay? Because everything is fitting into thyroid cancer.
Yes, sir.
CT is a must.
Yes, sir.
What CT you will do? CT of neck and chest.
Chest, sir. Yes, sir.
Yeah, neck and chest. It is a must. It is a must. CT is a must. Okay.
Then I'll do indirect laryngoscopy for
yeah, and for all the undergraduates, whoever is listening, ideal Srinivasan sir also will accept. I also will accept. But there are examiners who will say that yes, nowadays video laryngoscopy is what they insist upon while mentioning to know the vocal cord status. Both are right.
Yes,
yeah, video laryngoscopy, if it's available, like what we do upper GI scopy, you can see the larynx and the vocal cord movements.
Yes, sir.
It will have a better information than indirect laryngoscopy, which is
yes,
troublesome.
Sir.
Okay.
Yes, sir.
Fine.
So then I'll do an ultrasound guided FNAC, sir.
Yeah, very good. What is the malignancy you expect in this lady?
Sir, it's a poorly differentiated cancer, sir. Because of the fast growing status of the cancer, it's a poorly differentiated.
You are telling me the FNAC report, or you are suspecting FNAC?
No, I'm suspecting a poorly differentiated cancer.
Okay, means you cannot classify into papillary or follicular. That's what you mean?
Yes, sir. Without the FNAC
Okay, yeah, fine. I am very happy that you know there is an entity called poorly differentiated thyroid cancers. Yeah, very good. There is a definite entity wherein it is a fast growing and you cannot classify them in well differentiated thyroid cancers. It is a separate entity on its own, poorly differentiated. Very good. Even a pathologist will not be able to appreciate. That is why it has been labeled as poorly differentiated thyroid cancer. It is a like anaplastic.
Yes.
It is a definite entity, but comes under well differentiated cancers.
Yes.
Neither papillary nor follicular. Okay. So what is the treatment you would like to do for this lady?
So I'll do a total thyroidectomy with the central neck node resection, sir. And if I could see the other involvement of the other lymph nodes, I would remove those. I do a functional neck dissection.
On table, if you find out that there is a tracheal infiltration, what will be the treatment?
Sir, I will a resection of the tracheal resection, sir.
Okay. How you know, any idea how many tracheal rings can be resected and do? And if you know, it's all right. You've done nicely. You've done very well.
Two rings.
Okay, fine. Yeah. It is, we don't expect from undergraduates, but for information, you will be surprised if I say this. Maximum up to 6 rings can be resected and do end-to-end anastomosis, like tracheal anastomosis. Okay.
Yes,
it looks little like exuberant, but theoretically, yes. But people up to 3 comfortably you can resect out and do, but up to maximum, it's a MCQ question for you people.
Yes,
maximum up to 6 rings can be resected out whenever it is required. Okay.
Yes.
Very good. Okay.